Go ahead and start the recording and let people get settled, and then we can kick things off. Have a great meeting.
All right. Well, good morning, everyone, and welcome to the July Oregon Health Policy Board meeting. We're going to go ahead and get started. The Zoom chat feature in today's meeting only allows meeting attendees to message the host and co-host and no other meeting participants. Any questions, thoughts, and comments can be sent via Zoom chat to the meeting host or co-host. All materials for today's meeting are available on the Oregon Health Policy Board website and are hyperlinked in today's meeting agenda. We're going to go ahead and get started today with some important announcements. Healthcare Market Oversight Program, known as HCMO, provided its monthly update and its attachment number 1.1 in your meeting materials. If there are any questions or requests for the HCMO program, please let OHPB staff know or contact HCMO staff directly. Also, after more than 3 years, we are finally bringing back our in-person meetings next month. So that's really exciting. OHPB welcomes everyone to join us in Hood River on Monday, August 7th for this very special in-person meeting with community. Members and OHA staff will join local community from approximately 10 a.m. to about 2 p.m. The meeting will be held at One Community Health in Hood River. So please see the OHPB website for additional details. For those of you who can't join us in person, we will provide a remote participation option via Zoom. Also, we are currently in recruitment mode. We have several seats open on the Oregon Health Policy Board. Jessica Gomez has resigned as an OHPB member. We are thankful and appreciative of the time, energy, and the voice that Jessica brought to the board. We know she will continue to be an excellent advocate as she focuses her time on supporting Oregon businesses and the economy. Also, I will be needing to step down as from the board after our October retreat. I'm now serving as NEA Family Center's interim chief executive officer, so I will need more time to focus on this important role and support the organization during this very key leadership transition. So I will be working with my board colleagues, Kirsten, OHA leadership, and the governor's office to ensure that we have new board members and that a new board chair is ready to go by November this year. So all of this means we have a great opportunity and also a responsibility to recruit new members and voices to the board. We are actively seeking interested individuals to apply for OHPB membership. OHPB members are governor appointed and Senate confirmed. The next opportunity for Senate confirmation is September 2023. To be considered for the September Senate confirmation, applications must be submitted via Workday by July 19th by midnight. So all interested applicants are encouraged to apply. OHPB is particularly looking for applicants with lived, learned, and cross-cultural experience in behavioral health, consumer advocacy, community-based organizations, and small business owners. Information on how to apply is available through the governor's website and linked from the OHPB member page. So if you're interested in membership but can't make the July 19th deadline, you should still apply, and you may be considered for the November Senate confirmation hearing. So any questions from the board about any of those important announcements? All right, well, I'm looking forward to seeing everybody in Hood River next month. Okay, so for today's meeting, here's what we have on our agenda. We are going to get an Oregon Health Authority behavioral health update. We're also going to hear important agency updates from Interim Director Baden. I think we may have some public comments. We'll also get an important update on the behavioral health plan, and we will hear a summary of the 2023 legislative session. But before we officially get started, our first order of business this morning is to vote on the draft June 6, 2023 meeting minutes. The minutes are listed as attachment 1 in today's meeting agenda and posted on the OHPB website for public viewing. Is there a motion to approve the draft June 6 OHPB meeting minutes?
Oscar, do you want to do roll call? Do we have to do roll call? No. Okay.
We might have skipped roll call. Good
Yeah.
call, Sandy. Thank you. I was just kind of in my flow, so thank you for reminding me. So let's go ahead and do roll call. Tara.
Yeah, and it was a great flow. You're doing so great this morning. All right, I'll go alphabetical, but I'll start first with the chairs. Oscar Arana,
Present.
Kristen Isaacson,
Present.
thank you. Brenda Johnson,
Present.
Melina Moran,
Present.
Bill Kramer,
Present.
Sandy Sampson,
Present.
great. John Santa,
Present.
thank you. We currently have 7 members and all 7 members are present. Thank you.
Great, thank you. All right, now we can get to our first order of business. So can I get a motion to approve the draft June 6, 2023 OHPB meeting minutes?
This is Brenda, so moved.
Thank you, Brenda. Can I get a second?
Second.
Any discussion on the minutes? All right, all those in favor, please say aye. Aye.
Aye.
Anybody opposed? And any abstentions? All right, the June 6 meetings are approved. Okay, so Ebony Clark, our OHA Behavioral Health Director and also former OHPB member, joins us this morning with Jackie Fabric, OHA's Behavioral Health Deputy Director. Thank you so much for being here today. We're excited to hear your updates and learn how we can support you in your roles and support your work. So, Ebony, nice to see you. Please take it away this morning. Oh, Ebony, I think you're muted.
Okay, can everyone hear me now?
Yes, we
Okay.
can hear you.
Hard to figure out technological issues sometimes. So good morning, Ebony Clark, Behavioral Health Director. I have been in the role for, I want to say July 17th, it will be 5 months. And both Jackie and I both started at the same time. You know, just also want to take this public opportunity to also thank Jackie for joining and, you know, just really honored and appreciative to have such a great leader in Jackie to work alongside. So this morning, I want to say that this is really kind of our first discussion with the Oregon Health Policy Board in regards to kind of our work and our focus. And so today we wanted to just take a few minutes to just talk about what's at the center of our work in real time in this current moment, and then take some opportunity to then be in discussion with you all around just your questions and recommendations around, you know, key areas of focus and priorities. And we do have a little bit of a very basic slide deck to kind of guide at least our initial discussion. And so I don't know if y'all need us to go ahead and share that, or I don't know, Tara, I know we got it to you late, so I don't know if you can pull it up.
Yeah, I'm just sending it here to Badlands. So yeah, we'll have it up.
Okay. Okay. And Jackie, do you want to introduce yourself?
Yeah, good morning, everyone. I'm Jackie Fabric. I use she, her pronouns. And as Ebony mentioned, I'm the Behavioral Health Deputy Director. I joined with Ebony same day, so we're both approaching our 5 months. For those of you that might remember, I was with OHA before. I left a couple years ago to go work with hospitals and health systems and learn more about that side of the experience, which was a wonderful experience that I was able to now bring back to OHA and the behavioral health system. So thank you. It's a pleasure to be back here today, and I'm looking forward to giving you some updates on the work that Ebony and I have been doing since we joined OHA.
All right, so we'll go to the first slide, please. All right, and so, one of the things that I just wanted to highlight and clarify is that, in taking this position, I was a strong believer and supporter of the governor's overarching behavioral health priorities. And essentially, I believe that, the noted priorities, clearly speak to what the current need is as we have, kind of stepped out of the pandemic and are officially in essentially kind of our recovery phase of the pandemic. And so, much of what both Jackie and I do really is centered within the governor's priorities around working to assure that, we have accessible quality behavioral health services throughout the continuum for all Oregonians, to work to make sure that we are addressing the homelessness and houselessness issue and address the needs and bring forward solutions, especially for those that are impacted by mental illness or substance use disorder. Really working to make sure that bureaucracy and systems and policies do not get in the way of all Oregonians being able to achieve or receive the care that they have the right to. And then within that, really working to make sure that what we do is really rooted in equity. And I think y'all have heard me talk about, even before joining OHA, equity, whether it has to do with racial equity, health equity, geographic equity, and so much more, which means that we then to really make sure that we do have a diverse workforce that not only represents, the communities that we serve, but also knows how to bring forward, treatment services and supports that really are rooted in, community and individuals' way of life and healing. And so to be intentional around, for example, working to diversify the workforce, we have to make sure too that we're thinking about all the things that impact and come along with folks either choosing to not step into this arena or those that choose to leave. So we need to continue to work to push, parity for compensation with healthcare or primary care, for example, or how do we have parity between those who offer alcohol and drug treatment versus mental health services? How are we working to look at the workloads and address some of the administrative burden pieces, and how do we also essentially undo some of the unnecessary complexities that have been created over decades to people being able to step into and work in the publicly funded behavioral health arena. And then lastly, how do we make sure that we are promoting and ensuring emotional wellness and social wellness for our children and youth and families, especially at where we're at and with all the issues that we have as an aftermath of a pandemic. And so wanted to start with this slide because I wanted to make sure that it was clear and that we were explicit that this is what our focus is. And all the work that Jackie and I do in tandem with the Behavioral Health Executive Leadership Team and the staff, this is what our focus is. Next slide. And so to that end, you know, much of our work also at the ground level, at the policy level, at the system level, we're framing it in these three categories that were noted and framed in the governor's budget. So again, looking at how do you disrupt the pipeline from homelessness, jail, and hospital, and depending on the individual, it might be jail to homelessness, it might be hospital to homelessness or hospital to jail homelessness. How do we decrease and prevent deaths that are related to substance use and behavioral health challenges and needs? And then again, lastly, how do we stabilize and support a diversified workforce so that we can assure, you know, that all Oregonians have access to quality behavioral health care? And so, you know, again, you know, I know that y'all have heard and have been in probably many discussions around this, but oftentimes Jackie and I are asked, you know, well, what's your focus? What is your priority? And this is what our work is rooted and framed in. Next slide. And to do this, you know, I have often talked about it's a collective effort, not one individual, one provider, one holder of the system can solve for all of the behavioral health issues and challenges that we are navigating in the moment. And it truly takes a collective effort. It's not me, it's we. And so this is a slide that really kind of captures, you know, our vision in terms of partnership and collaboration to get out of, you know, this, you know, siloed, you know, kind of approach that I think systems often find themselves in. And so, you know, our focus and our goal is to really make sure that, you know, what we do is supported by community and lived experience, voice, you know, and how do we really make sure that we are in a process where we're co-creating solutions and not being top down. We want to, again, continue to make sure that what we do really is rooted in a true equity approach, which means that we will have culturally specific and linguistically specific and so much more specialty services that really meet the needs of the vast, unique individuals that we serve, with, you know, us doing our due diligence around being stewards of public funding, taxpayers funding, to optimize, you know, all aspects of funding streams. And, you know, this other piece is, you know, there's a line that talks about, and then how do we, you know, not only streamline, you know, my hope, my vision is that, you know, again, we will quickly get to a place where we can have these various dashboards that speak to the impact of our work. And that's really centered around transparency, being outcomes oriented and accountable, and continuing to really work to identify and bring forward emerging practices, promising practices, best practices, because as humans, we evolve, and so much is different now than it was 20 years ago, 5 years ago. And it's important that our system and our behavioral health continuum of care continues to keep up to meet the current day needs and issues and challenges that folks are grappling with. Next slide. Jackie, do you want to talk about this one?
Sure, I'd be happy to. So to build on what Ebony has been saying, we also look at the values that we hold that guide behavioral health and that we hold as, you know, as leaders, as in the behavioral health sphere and as the behavioral health system. So as Ebony had already talked about, really centering this work in equity, having it is really the foundation for everything that we do, and including equity in every policy decision we make, and how we engage with our community and our stakeholders as well. And that leads also to that we are directed by people with lived experience, that we listen, we connect, we collaborate, and we engage early and often with people with lived experience, so that we can build a system that is going to be responsive to the needs of people that will be engaging in services, and for families that will be engaging in services. We also talk about whole person care, so that we're not just treating a symptom, that we need to move past the days where we have substance use disorder treatment separate from behavioral health treatment, separate from physical health treatment. But we're really looking at the whole person, not just a part of the individual. And that is guiding how we're building our system, how we're improving our system, and then how people are receiving. The fourth area that we really have guiding our values is in prevention. So how are we preventing from escalating behavioral health conditions and disorders? How are we working with communities, schools, with individuals, with families, to prevent substance use disorder and behavioral health concerns? So really that we've long talked about the need to move upstream, right? So how are we moving upstream? And then lastly, recovery and reintegration. So how is our system responsive to the ongoing needs of individuals? That we know that you know, things don't follow a straight line. So how are we ensuring that we have a behavioral health system that is focused also on recovery? And when we think of you know, where someone might receive treatment, how we're ensuring that it's integrated into their local community, into their homes, and into their lives, so that we aren't treating people separately. Next slide, please.
So basically, this is the best visual we have thus far. And it's pretty basic, it's pretty simple, and it's not fancy and flashy, but this is a visual of Jackie and I and the behavioral health unit's work. And this is what we're focusing on. And this is what our current priorities are, as you do the overlay of the governor's priorities. And this is the work that's bookend essentially in the governor's, you know, vision for how to improve and enhance the behavioral health continuum of care for all Oregonians. And I'm sure that there are things that are missing, so thank you for your grace. If there's something here that you're like, I don't see this. This was a quick kind of, you know, let's put everything that we can think of, you know, visually out that, you know, we're working on in terms of, you know, big policy or priority areas that are equally important. And you know, we couldn't take a tiered approach or phase or weight what is more important than the other. These are all equally important and priorities in what Jackie and I and the behavioral health group is working on. And when you look to the left, you know, we're doing that while working to then stabilize the OHA behavioral health leadership team and workforce, just because, again, as y'all are, you know, familiar with and continue to hear from probably so many different systems and providers, that we too are working at a deficit when it comes to staffing capacity. I don't have the specific numbers in front of me, but the last time I checked, I want to say that, you know, we were looking at a capacity gap of probably about 45 to 50%, and that's a very conservative estimate. Again, these are our priorities and our core areas of focus also, while again, working to make sure that this is directed by individuals with lived experience, centered in equity and community, not losing sight of how do we do better at being outcomes oriented, and how do we do that in a manner where we're holding ourselves accountable, and that's a value that we're able to live out in all facets of what we do, in addition to being transparent and collaborative internally, externally. This is what Jackie and I are working on. This is, the key areas of our focus and priority. And Jackie, I don't know if there's anything else you would add to this before we go to the next slide.
Well, I'll just acknowledge that there's a number of acronyms on here, so that we're happy to provide those. And as Ebony said, even as I'm looking at this, we have the 23 session to add to this, and there's a number of things that are being built out on each of these as well. So this is just a really quick snapshot of the work that we're doing of all the different areas, and that we are really focusing on incorporating our values throughout each of these. Go ahead, Ebony.
And Jackie, feel free to jump in too. I mean, sorry, just this visual, it's a lot that I'm just like, ooh. And so it dawned on me, we probably should kind of walk through just a couple of these to kind of give examples of what we mean. And so when we talk about the overdose crisis, we currently are experiencing, the aftermath of what we see as a result of the pandemic, specific to the illicit substance tridemic is what I like to call it. And, outside of just fentanyl and xylazine, we have a crisis specific to meth, and meth has been, an issue for quite some time. And so when, we think about the illicit substance crisis, that's one of, so when it says overdose crisis, really, that's what it's framed in, and thinking about what is our response in terms of how do we, number one, educate and inform and work to provide solutions, whether it's overdose prevention to harm reduction to treatment services, in addition to looking at how we leverage peer services and then digging deeper in terms of and what else do we need to be doing to get ahead to mitigate the illicit substance crisis. We're focusing on our work for aid and assist, and I'm sure that y'all have heard about the Mink-Bowman judgment, and OHA Behavioral Health is working in partnership with the Oregon State Hospital to solve and to come into compliance around how do we really do all that we can and move the system forward, so that we don't have individuals either languishing in jails and or the state hospital. And so when it says aid and assist Mink-Bowman, that's what that one is. We're focusing on continuing to move forward and uplift and support the Measure 110 efforts. We're, getting ready to go into the next phase of that. The Q2 report just came out and showed that, it looks like there continues to be an increased utilization of services provided by, I want to say, the 42 burns across the 36 counties. And I think, folks are using peer services and harm reduction services the most. And at the same time, the report indicates that there has to be further work to do better with our communities, especially. I want to say that when I looked at the Q2 report, and there's a public dashboard, especially around the African American Black community. We have just launched our behavioral health residential study that I was directed to engage by the governor to really look at what does our facility-based residential services look like in terms of, what do we have across the state, and how do we look at it, from, our region standpoint. What are the services, what are the supports, what's the capacity, what are the gaps from mental health to substance use, to then hopefully inform a recommendation of, what's the future forecast around capacity that's needed for residential levels of care, while then also overlaying that with a cost study to look at, helping us get at an estimate around the dollars that it's going to take to move that forward. Jackie, I'll let you talk to some of these. The last one I'll speak to, because I know that I'm mindful of time. The 21-23 investment, the legislator, passed and provided so much funding in the past biennium. And, so one of our continued areas of focus is, continuing to look at the impact and the current outcomes around the 21-23 investments to then help also direct and guide future investment, especially coming out of this current biennium. Jackie, I'll hand it to you to talk to a couple too.
Yeah, so I'll start with the 988 system. So 988 provided a unique opportunity for all states. It turned on a line similar to 911, so an easy 3-digit number that anyone can call when they're having a behavioral health crisis or they have a family member in a behavioral health crisis. We just had the anniversary of those lines going live. They went live a year ago, and so we do have an active 988 line in Oregon, and we also have mobile crisis available in every county. We've had mobile crisis since 2018. However, we need to build up our mobile crisis so that it's able to meet the needs of all the people in Oregon with the 988 system going live. So we have the phone line, then we have responders that can go out and respond to behavioral health crisis. And we are working on finalizing rate setting with the for mobile crisis with our CCOs and with our our community mental health providers in each county. And then we need to build the stabilization center. So we need a place for people to go, because historically they've gone to emergency departments. So how do we develop places for people in behavioral health crisis to go that are going to be responsive to their needs, that are no longer going to overburden emergency departments? So that's the third piece that we're working on building out, while we're continuing to increase capacity for the phone line, build out the mobile crisis teams that we need in each community, and then develop those stabilization centers as well. The other one I'll speak to is the CCBHC, which is the Certified Community Behavioral Health Clinics. Oregon was one of, I think it was 8 states that had a demonstration starting in, I think it was 2018, might have been 2016. I'll have to check my numbers. We are now to the point where we need to make a decision if we are going to continue with the CCBHC programs. The Certified Community Behavioral Health Clinics are a national model that provide comprehensive behavioral health care, and they also can integrate physical health care into them. So I kind of think of it as we have the patient-centered primary care homes. This is a certified community behavioral health clinic that that is able to integrate physical health and provides comprehensive behavioral health care to individuals. We do have a number of programs throughout the state of Oregon, but we need to make a decision if we're going to apply for to continue this program to get the Medicaid match through a state plan amendment through a SPA. So we're working very closely with our CCBHCs and developing what that SPA would look like, how we would continue to maintain those certified community behavioral health clinics with that Medicaid match for Oregon. And then lastly, the last acronym I want to speak to is the CFAA, which is our, now I'm going to forget the acronym, it's our county contracts for the mental health programs that are required through statute in each county, and each of those counties provide safety net services. Oh, hi, Tara, is that better? Can you hear a little better now?
Yeah, I think it's a little bit. I can hear you. It's just, it could be improved slightly.
Okay, okay. So
Yeah, that's better. That's better.
I'll talk louder too. So the CFAA is the contracts essentially that we have with each of those mental health programs in each county that are responsible for the safety net behavioral health services. So those have not been significantly updated since in decades, really. So since before the CCOs came on board. So really looking at what are those contracts, what are in those, and we're working collaboratively with the counties in reviewing and evaluating those contracts as well. Ebony, I'll hand it back to you.
All right, so I'm mindful of time, and so the next and last slide, oh, there's 2 more slides. So this is just kind of a high level snapshot of kind of current challenges that I'm sure y'all have, consistently heard about in terms of, the issues that we are having to solve for and navigate and mitigate. So, some of those are, capacity limitations that, have direct through lines to workforce challenges, and then cause gaps in services. We continue to, see, the siloing effect and disjointedness that, again, it's how do we really get back to being centered and directed by, those with lived experience, community, and key stakeholders. And, I'd say that this effort of collaboration, integration also applies internally too, not just externally. We continue to see the acuity of behavioral health challenges that have been exacerbated by the pandemic, and then the illicit substance crisis that I spoke to earlier, specific to meth, fentanyl, xylazine. And so, some of the things that we're doing is, the continued inventory and gap analysis, guided by, to help guide targeted funding and policy and program strategies and solutions and investment. The residential facilities assessment that should and will build on the SUD inventory, in addition to working to prioritize workforce incentive efforts to fill critical areas of need, and then just continued effort in really living out that value around engagement at, even before the inception of a effort. So it's just, and there's so much more, and we could talk forever. So then the last slide was that we were hoping to also, just make sure that we begin to step into intentional conversation and dialogue continuously with you all around your recommendations, around our work, our focus, our priorities. And so, we, are happy to hear from you all today and in future conversations specific to, your recommendations for us in helping us achieve the governor's priorities. And then, just wanting to also, just so that we can be transparent and action-oriented, what cadence would you then like us to come before you to speak to, just the status of our work. So that was the last slide. So I think we probably can take the slide deck down and see faces. So thank you for having us and happy to answer any questions.
Thank you so much, Ebony and Jackie, for your presentation and for being here this morning. Really appreciate all that you're doing in your relatively new roles. So let's go ahead and open it up to questions. Bill.
Hi, Ebony and Jackie, thanks very much for this great presentation and all the work you're doing. I know that the focus is on people who are in crisis and have severe chronic behavioral health issues. I did notice, though, something on your list of challenges that made me think of one additional issue. You noted that pockets of siloed or disjointed services. And I know there have been a lot of efforts, particularly in the commercial space, to integrate behavioral health services with primary care services. And I assume that's also the case to some degree among community health centers and so on. I wondered if you could, I looked in the presentation, didn't see anything related to that issue of integration of behavioral health with primary care. Is that an area that you're working on, or can you just comment on that particular part of the broader effort to improve behavioral health services?
Ebony, you're back on mute.
Thank you. Thank you. We'll make sure that, and as we continue to refine our visual, that's clear. But I would say that, when we're talking about, getting out of this siloedness and, reintegration and collaboration, I'd say that it falls within that realm. I think that some of the kind of specific projects and examples of that would be some of the efforts that, we're trying to do with, the work around CCBHCs, and there's other areas as well. And so I think that when we do think about just even backing up to before the pandemic, system transformation and integration was a priority, and we can continue to be explicit about that. And the next time also speak to that piece. And, as I said earlier, this was kind of just a quick snapshot of just, what came to mind, and there's things that I'm missing. The other thing that we need to be explicit about that we can put up there and speak to the next time is the work that we're doing when we think about older adults, because essentially, there's work across the continuum and the age span as well. And so, yes, hindsight is 2020. So thank you for bringing that forward.
Brenda, and then we'll go to Sandy.
Thanks, Ebony and Jackie. It's great to see you both here. And I'm really struck by the last slide, which is a question about asking around OHPB's involvement or the frequency and cadence of connecting with this important body of work. As I looked at your priority slide, I was struck with a few thoughts. One is, and I appreciate very much the fact that you're both 5 months into this role, that you're entering into an incredibly complex system with a lot of moving dynamics. And as I looked at the priority slide, I thought, that's a lot, and I can't find the priorities. And so how do we think about where those programmatic efforts are kind of stable or in motion? It's an activity kind of chart where there are other efforts that require so much more of your time, attention, and lift, and that for the agency. It would be helpful, I think, for this board to have a little bit more spread or differentiation to understand that picture or to help inform it in some way. And so I leave that both as a reaction to what I saw and mostly thinking about, gosh, what do we do together? Do we need a study session? Do we want to think about where we can be most helpful in helping set some of that guidance in place? And yeah, I'm left with more questions than answers, to be honest, but I'm deeply interested and engaged and excited to do this work with you. Yeah.
No, thank you for that. And I'll just say that, the behavioral health is such a critical area a focus that is important, for us to be front and centered at. And I think that, just to be fully transparent and direct is that the work is daunting. And as we think about the various areas, quite frankly, there's attention that's needed in all those areas. And so again, it's I totally agree with you, and happy to also kind of talk about, in the future, just, kind of what our iterative and phased approach is in responding and supporting and enhancing, the work, so that it can move forward, so that it can also be sustained, and so that we can also kind of really start to get to these desired outcomes, and aims that we have. But, I think, for folks, I mean, y'all know me, so I just put it out there.
Yeah.
It's not just one area that we need to focus on, and then, and so that I think that's one piece, is that we're trying to be transparent that, there's, key areas or multiple areas that really do require Jackie and I's leadership, when we think about, strategy, policy, sustainability, and so much more.
Yeah, Ebony, I'm so glad you said that. I'll just kind of reflect a little bit again with you. Just I love that we know you, number one, and that we know that this is so critical to the body of work for the agency. It's such a big priority for the governor. It's really, our board, both when you were here and sitting on it and your leadership, helped elevate the importance of it. So I want to just reemphasize that. I'm also thinking that, as you said, if I were sitting at a 50% vacancy rate, or 40, whatever number you said, with recognizing the workforce needs within the agency itself to be able to execute as many things as you have on that list. I'd be thinking a lot about how can we say, yes, it's important, but we're not going to actually tend to it right now, and to offer you some support around those trade-offs so that we can think about, because some really aren't going to get attention. We want to be transparent, to your point, because you simply don't have the capacity to do it while we build capacity. So I think that could be an interesting role for the board to help, think through and say, this is the heavy lift, and let us all go all in on these few things instead of try to, boil the ocean. It's an incredibly daunting task. Your word is really well spoken. So I just want to offer that as we think about it together. Yeah.
Yeah, no, that's music to my ears. Thank you.
Sandy.
Thank you. And thank you, Ebony, for the slides. When I look at the behavioral health resource network and the dollar amount that actually goes to counties, I was looking at Umatilla County, and, the dollar amount that was, there was an award of about $5.3 million, and per person was $69. So when we start looking, at the bigger picture of continuity of care for individuals, and I appreciate the silos, tribal organizations a little bit different, but, because of the shortage of workforce, I think that's the critical key, and I appreciate the lived experience. And, the tribal organizations, the 10 tribes in Oregon, and also NARA, that services a multiple tribal tribal people in the metropolitan area, urban area. But we actually did, and I think it's probably good for a lot of communities, you're looking into the community itself. We did a tribal preservation. We worked with Health Equity, Office of Equity and Inclusion, and did our own curriculum developed specifically for tribal organizations. And what we ended up doing was we really pushed more of our cultural related type services, the lived experience, wraparound services, and focused on the, centered the focus on the person. And those lived experience are I know that when we look at tribal health, when we look at the peer delivered services through Office of Equity Inclusion and certifying those individuals to become mentors with the lived experience seems more critical for different ethnic groups, because they understand what's going on with the person. We did tribal best practices specifically for tribal organizations. So I know it's hard. We have through the Northwest Indian Health Board, we have a CHAP program, community health aid program. They can be certified in a shorter time. When you're looking at MSWs, 4 years, our workforce we just can't do that right now. So I really like to see it centered more into the community itself. I'm just sharing the tribal one because it was critical to develop that curriculum to they were able to build just like a MSW. I mean, if you're a social worker and that billable service through that program was, it was critical, but, they had oversight of, from whatever care plan they developed. But, for us, it's our culture is so important, our sweats and doing different things with our children, our adults, and those wraparound services, like Bill was saying, with healthcare itself. So, but we have a behavioral health aid program, we have a community health aid program, we have a DHAT program, a dental health aid therapist program. And because of the shortage in workforce, it's critical to, maybe shorten some of that time up to get individuals and workforce development implemented. So I just wanted to share that, and I do appreciate your slides. And just looking at, the last couple quarters was great to kind of do that vision. So thank you.
John, you're up.
Yeah, gosh, Ebony, it's great to see you and hear you again. And boy, do you have a hard job. It was informative to hear the discussion between you and Brenda. Like Brenda, that slide with all your priorities was that one in one way impressive, at the other daunting, if not impossible. And it certainly, I think, is appropriate to ask, well, how can OHPB help? and help in a way that actually doesn't complicate things? Because, I think in the previous administration, OHPB was asked to step back from mental health in order to make it clear, who was in charge and who was leading the way, and that, the relationship became one of keeping track of what was going on and having the benefit of your presence on the board really helped. So, I think in many respects, your response to your last slide is, how can we help without causing more problems? There's certainly two historical issues that, as you spoke, I thought of. I don't think that the physical health system is still performing as well as it could be when it comes to the population of folks who have behavioral health problems. We have a metric for that. We used to incent improvement in it. We no longer do. We recently had an ombudsman report that had at least an anecdotal example of just awful care in the physical health system for a mental health patient. And you know, the lack of good physical health is killing people with behavioral health problems. And I think we could really get more serious about that. That's one idea. The second is, again, you know, looking at your priority slide, I think that there was only one priority box that explicitly mentioned children. And that was a high priority in the previous administration. It was a high priority here. We spent a lot of time around children. You know, that was reflected, of course, in CCO 2.0, and then with the new waiver, with the expansion for children. And, you know, my major exposure to it was through the kindergarten readiness metric. You know, you can't make progress on something unless you keep track of it, and unless you have a systematic approach to it. And I think that metric and the work around it was really powerful, and I hope it continues, and I hope that that population of Oregonians remains a priority for this administration, and that includes for your work. So I think it would be great to hear how you all are doing quarterly or every 6 months. And I also think it would be great for us to hear from you. Help. You need to do something in this area to help us, and that the board should take that seriously and do it. So thanks so much for what you all are doing, and hang in there.
Thank you so much. And, you know, again, too, this, you know, lots of great feedback. And, you know, I think, you know, in that visual, I would say too that, you know, yes, because children, you know, it's about across the age span, and our work for CCBHCs, you know, Measure 110, when we think about admin burden, when we think about social determinants of health, when we think about the Medicaid waiver, when we think about community engagement, that encompasses kids, children, family, and youth. And so I think, you know, one of the things that we can also do is, you know, really talk about kind of that overlay across, you know, the work that has, you know, the through lines across the age span. So helpful, appreciate the feedback. And, you know, I think that, you know, there's some pieces, you know, especially through legislative policy and, you know, some of the work that, you know, has to continue. And so I think it's how do we kind of, you know, show this iterative process of just, you know, where we're at with kind of moving forward, you know, some of these key areas of focus that, you know, the last thing I'll just say too is that kind of, and I don't mean this directly because I'm new, but as we navigated the pandemic, there were things that, like, you know, it was all hands on deck, and focus was working to, you know, uplift and move forward the response to COVID-19. And so there's some pieces that, you know, we're going back and, you know, also trying to, you know, assess and say, okay, so this was paused, or, you know, we need to finish moving this forward, or we need to decide where we're going to go with this, you know. And so we're also in that process of, you know, trying to clean up a little bit of the aftermath of the pandemic, and do appreciate all of the input and feedback around, you know, when we get to come back and, you know, be able to kind of just show, you know, just the iterative work and how we're phasing, you know, our focus and priority, again, you know, rooted in the governor's priorities, rooted in equity, rooted in being directed by lived experience, and so much more. So appreciate being here, appreciate the questions, and look forward to the continued collaboration and your input. So thank you so much.
Thanks again, Ebony and Jackie. I have a couple of comments, but I want to make sure before you jump off, if there's any, Kirsten, anybody else who wants to say anything. Okay, well, again, thank you for your time in the presentation. I was, I feel like even the slides that we saw today was kind of like one of the first times that we got a better understanding of all the work under behavioral health. So, congrats for only being in your roles in 5 months and already sort of presenting a much more clear picture to the board of everything that's under your scope of work. I was really struck by that, approximately 50% capacity gap, and the fact that maybe that is a safe estimate, potentially an underestimate, right? So I'm kind of curious to hear more about like, what are the challenges? I mean, are this just like general workforce issues, or is it like, that plus like, what is causing that like gap?
I would say that, our challenges and gaps mirror what community is experiencing, so I'd say that, some of the issue is compensation. Some of the issue is workload and the acuity of those that we're serving. There's individuals where, again, depending on the pay, can go and do something maybe a little bit less stressful or overwhelming. But I would just say that, people are just right now like reassessing, how they want to spend most of their day. And so again, I think it really is centered on compensation, workload, acuity. And then again, there's just, like I said, this kind of backlog, as a result of the pandemic, of kind of also reassessing, the work and, what's critical. And so then what we need to prioritize and, trying to recruit for. And I think the other thing is, just like many providers out there, we've had recruitments that have been posted 6 months. I've heard some stories of 12 months and, didn't really get interest. And so I think it's just the same themes that our partners, providers, and communities are experiencing. So.
Thank you. That's really helpful. And then, I think, I think with this line of work, it's really about a marathon, right? So it's like making sure that you're sort of like figuring out, how you're going to be in it for the long haul, because all this change really requires a lot of time. So that's really helpful. Thank you. And then to your last question on your slide is, we're getting ready to have our retreat in October here, where we're going to really have these robust conversations about the board's priorities for the next couple of years. So we've been working with the governor's office as well as with OHPB members, and we welcome you and your feedback as well as we get prepared for those important conversations in October to really, like Brenda was saying, right? Like, make sure that we want to elevate your work and we want to support your work, and we also don't want to create more work on your already busy workload. So thank you again for your presentation, and yeah, we will continue to be in communication.
Thank you. It's good to see all of you. Thank you so much. Take care. Bye.
All right. So we have Director Baden, who is now going to provide an agency update. Go ahead and take it away, Dave.
Yeah, thanks, Oscar. Good morning, everyone. Dave Baden. I use he, him pronouns as the interim director of OHA. First, I caught at least the back half of Ebony and Jackie's presentation. Just yeah, thanks for the board's thoughtful comments, and obviously big governor's priority, a big priority for every Oregonian to improve the behavioral health system in the state. I just want to shout a lot of kudos to Ebony for her efforts coming in a frankly a really rough time into an organization under a lot of significant transition, and to be able to sort of to hit the ground running, to make sense of the world that she came into, but just getting out there and chatting and talking with so many people around the state about what's happening and where we need to go. I look forward to partnering with her to keep pushing in this area. There's a lot of work to be had. So just thanks for Ebony and Jackie and all of her great work. So I have a couple of items that I wanted to highlight today. I think there's later a legislative update, so I won't sort of get into all of the nitty gritty of what the legislature ended up doing for OHA, both on policy bills and new budget and positions for a variety of items. But I wanted to highlight a couple of pieces. Frankly, I hopefully that you'll know I'll be pretty blunt and honest with you all of where the agency and where things aren't necessarily going as well. And actually, I want to sort of take a couple of opportunities to talk about things that I think are going pretty well, and I think are just examples of Oregon's commitment to really try to move toward universal coverage, and where OHPB has been on the forefront of doing that. First is how the state is approaching the redeterminations process, and all of the policy levers that we talked about putting in place by having a temporary expansion of Medicaid from 138 to 200% to catch folks as we're going through redeterminations. And I always I come here with both a hopeful message on how I feel things are going so far in redeterminations, and always a little bit of not wanting to overpromise and underdeliver here. We're still early. There still are a lot of individual cases of people that need to provide information back in order to determine, income or other sort of eligibility criteria that we're still kind of in the middle of, even the ones that started in April, of sort of getting all the info back on those cases. Because if I take a sort of a half step back, and there's been a lot of national stories and other stories about other states where, we're talking 30+% of, their Medicaid members through redeterminations losing coverage. That so far is not Oregon's story. And I want to say this with both hope and joy and thankfulness for how we are approaching this, but then always a little bit of what's in front of us, because we do have a lot of work in front of us. Really, as of just as a reminder of sort of where we're at, is that we're sort of going through rolling 3-month cycles, and we just sort of ended the first 3-month cycle, April, May, and June, and had sort of the first set of folks that are getting into their notifications of losing benefits of 60 days out. And there were some people that either were found out that, like when redeterminations happened, that they had moved out of state or other things. Those closures happen a little bit more immediately. So around, I'll get into some specific numbers here, but really want to encourage, and Tara, I think, will put in the link to the dashboard that is out there, that is updated daily, to get a tally of how things really are going. Again, as a reminder, we're going through renewals, medical renewals for 1.5 million people that began in April and are going to continue through March of 2024. We have a dashboard that now has been updated in a variety of ways. We've sort of rolled this out in phases. It now has, redetermination results with percentages of those successfully renewed with benefit reduction and closures, including the reason for closure, much more information on race ethnicity data, some county specific data, percentage of renewals. So I just encourage board members to take a look to really dig into those pieces. We do have one more final phase coming on that piece that we'll talk about total workload, because Medicaid redeterminations are also going on at the same time of other sort of SNAP and other renewal pieces of talking about total workload on the one eligibility system, including food cash and childcare, volume and timeliness of applications, changes, renewals, et cetera. And I will say again, things that we really were worried about in the first 3 months, the overall wait times and sort of call center issues have been impacted, but not maybe significantly as significantly as we were worried about. So, for example, our dashboard is updated daily for our one customer service call center. The overall contractor that we have helping with us, their PH Tech is we contracted to have them help the call center. They remain on target with their daily average wait time, frequently resting at 30 seconds or less, Monday through Friday. So people that call are getting answers quickly. There are sometimes, when there are, then referrals to people when there's more specific questions for a little longer wait times to get those pieces done. There's a callback function that we've used a few times, but by and large, there have not been, I would say, overly dramatic wait times that we were worried about in this first 3 months. And frankly, June was sort of the big month of that was sort of the last of our rolling 3 months in doing that. So I'm excited for that. So just a couple of quick numbers. As of July 6th, 363,122 individuals have been successfully renewed. Then we have sort of other categories of benefits or cases closing that only 32,000 individuals have benefits closing. Again, that sort of got that 60-day notice, and 17,000 cases are closing. I will say what I'm really focused on and what I've asked the team to really be focused on are how well we are getting uptake from people who need to provide additional information. So since Trilby's on camera, I'm going to use Trilby as my example. So let's say Trilby was in this first round and Trilby got the information of, hey, you need to provide additional document, go make an appointment at the local ODHS office to do that. That is more work for Trilby to do. That is the sort of a big focus of CCO work, of work with some community-based organizations to try to assure that those people aren't falling through cracks. Because Trilby might be eligible, right? Trilby may indeed submit information and she retains her Medicaid benefits, or maybe Trilby submits paperwork and she's over income or whatever level and she's not eligible for above 200%. She gets a referral to the marketplace and she goes from there, or maybe she has commercial insurance in those pieces. So I will just stop, and I see Sandy has her hand up of so far. I will say that that I think I and others are pretty pleased with the results to date. a really big focus on those cases that that do need to provide information. There have been a lot that have returned their information. It doesn't, again, from the team's perspective, there will unfortunately be some people who will, drop because of those circumstances. We haven't heard of big, gigantic balls of return mail showing up. So I do think that a lot of the planning efforts have helped. So I am in the world of being the interim director, I'll say I'm cautiously optimistic 3 months in of the redeterminations process. So let me stop there, Oscar, and then I do want to talk about Healthier Oregon here as a second, but I see Sandy's hand up.
Oh, I was just curious. The one customer service center dashboard, like Monday, the awaiting time, abandoned calls just went skyrocket. Is people just trying to was there any difficulty in getting through?
Ooh, good question.
I was just curious. I mean, you've had a pretty average June 26 was kind of high. It's been pretty steady throughout, and then all of a sudden you're off the charts. So I was just curious.
I do not know that answer, Sandy, but let me see, Tara, see if we could find things out during this time, if there was anything specific that Nate Singer or others could help us find out. Ooh, Ali maybe knows the answer. This is great. I'm phoning a friend. Ali.
Thanks, Dave. Yeah, generally Mondays are pretty, I think people think of things over the weekend, and generally Mondays are usually the highest number of inquiries, calls. As far as the wait time, that's something that we can follow up on.
Yeah, your abandoned calls were almost the same as accepted calls. So I was just curious that are people starting to worry about, getting hooked up with the Oregon Health Plan? Because
right,
just looking at your dashboard of, individuals on the renewal that's initiated, not started. When you have 917,968 people, but you do have almost 500,000 completed. So it's great, but it's just, I was just curious if there was something associated, looking at your dashboards and data that you have available.
Yeah, no, it's a good, thanks for closely looking at that piece. Yeah, I mean, to Ali's point, and I think we could follow up again. I mean, if you're sort of looking at the trend since April has been a little bit up, if trying to put a trend line in data here, there. But again, I think it maybe not as dramatic as others, and to the point of that there are days in individual cases where it is still hard and too long and abandoned calls. So so both of those things are definitely true. So again, generally cautiously optimistic about the number of actual closures that we have as compared to the number of renewals that's going on. All right, well, I have to leave here in about 5 minutes, so I did want to spend a couple of minutes on Healthier Oregon. Again, to the continued expansion for people in Oregon, the legislature, both in the governor's budget, now that the legislature has provided resources, we are now have fully open coverage for all eligible people in Oregon that would qualify under the Healthy Oregon program. I just saying those words is awesome. For people who have been fighting for their whole lives to push for this in this state, to be able to say that that we are that we moved 40,000 people over in early July from column-based emergency coverage only into full coverage. It makes me want to show up every day. So I I just want to just say so much thank you to all of the individuals and people and organizations that have pushed the state to do the right thing. I could talk about the great work that our teams have done, because they have done great work, but community and those impacted here and their push and desire to be treated as to be treated as human beings and to receive health coverage that they qualify under income standards. And what they didn't qualify for is because they didn't have citizenship. We now in this state have said, you know what, if they meet income qualifications, they should be able to get health coverage, and they should be able to get good health coverage. That's what we've done here. So we have 40,000 people who moved over. We are going to, continue to work then. It's not, of course, everybody in the state, but working with CBOs, more media partners, there'll be TV, radio, and digital and social ads starting later this July, to do this. Those people that have moved over that had citizenship waive medical benefits, about 2/3 or 3/4 of them are already connected with an OHP community partner. So they have some linkages for understanding what their new benefits are and how that they work. It's really excited to be at this point. And I will, of course, say that just having access to insurance and getting that card that does not mean access. That there are still big challenges in this state, big challenges in the CCO network, big challenges in the fee-for-service network to assure that there is the right type of providers, the right type of translation services, the right type of ability for people to get the healthcare that they need. So we have a long, long way to go. Excited to be at this point. I did want, before sort of leaving here, and maybe, with just sort of a thing that I've been thinking about. I've been chatting with a couple of hospitals and asking them to think through this too. But I am just really interested in, now that we have moved 40,000 people that had emergency only coverage into Medicaid and to Medicaid-like benefits for the population, what will be the impact on charity care in hospitals, right? So I guess my hypothesis, and would be interested in, OHPB sort of thinking of this, is that it should have an impact on charity care. Now, how much impact and what percentage of their charity care were people who showed up and sort of went into further hospital services from the emergency room, that didn't have citizenship that did not have American citizenship and were in that. I know that it's a portion of them, right? I'm sure of it. I've heard stories about that. And what will then be the impact from that? Is this a sort of an overall cost savings to the system? I'm just going to throw out sort of hypotheses that I will admit that I don't know if I have all the data behind whether it will or not, but I think it's an interesting sort of look as we roll out over the next couple of years to see if there is an impact on charity care. But again, I just wanted to sit and thank Community First and thank all of you for support and a push to keep this program going. This is going to save lives, and just having people that can now get preventive care, go into a dental cleaning and not have to pay for it, or focus on some free dental care that may show up here and there. This is a really big deal for this state, and excited to be part of it. All right, that is my, I will sometimes bring hard news, Oscar, and today I'm bringing good news.
Yeah, it's wonderful to hear. Congratulations to the entire OHA team for all their work, and to community members who have been working on this for so many years. So I know you have to go here pretty soon, Dave, but does anybody have questions for Dave? I'll go ahead, Kirsten.
I don't have a specific question, but I did want to follow up to just say this is spectacular, a spectacular step forward in removing a barrier to health and a large step forward. And so congratulations to the state of Oregon, like small s state of Oregon, like to everyone, because this was had many hands along the process, but especially to the OHA team who more immediately is implementing it. So that is spectacular. I did, I do think we should watch those charity care numbers. It'll be interesting to see how that impacts different systems too. And will probably be a tale, could be a perspective of was the system happening where it should have happened? And if it was, we should see a reduction. No, go ahead, Dave.
No, go ahead.
And then I wanted to highlight these portals as just they're representative of a lot of work, and it's one particular lens when we think about like average wait time and abandoned calls. And I recognize that it's a slice. But it does seem like a good kind of canary in the coal mine type slice. And so I really appreciate that we have these dashboards that are updated so regularly. And so we are able to be like, oh, something's happening in early June. And if it continues, can be addressed, and hopefully it doesn't. But I just wanted to highlight the value of this transparency and the openness to accountability that I think it reflects.
Yeah, thanks, Kirsten. We got a long way to go. There of course are going to be current Medicaid members that are not going to be renewed successfully that should have been renewed successfully. That sits heavy on all of our hearts because that's what we're trying to avoid. And trying to do what we can to avoid those and have people continue with appropriate care that meet Medicaid qualifications.
Looks like John has his hand up. Go ahead, John.
Well, Dave, I would say charity care is interesting, but in the old parlance, I think the hospitals used to say, well, there's this huge cost shift that we have to put on employers to cover the deficits we have for taking care of the uninsured. I'm wondering if with the advent of Healthy Oregon, hospitals are sending out letters to employers saying hundreds of millions of dollars is going to be coming off your healthcare costs because of this. Mm-hmm. If you see a copy of that, let me know.
Boy, there's so many things I want to say, John Santa. I will let you know. How about that?
Dave, a really quick question, more of an organizational kind of question. I was curious, obviously the workforce challenges are something that we've heard from Ebony. We also know workforce challenges are affecting the redetermination process. And I'm more curious about workforce challenges within director level positions at OHA and leadership level positions at OHA. Curious to hear. I know that we are in Modus just did a webinar for the board members around the search process for the OHA director, but I'm curious more about direct reports to the director, like vacancies, and then sort of process of where filling those vacancies are at.
Yeah, no, thanks for the question. I think we are, and I just don't have the latest update, but the HPA director's position, if it has not been posted, should be posted very soon. I did not get an update prior to that for recruitment. I think some of the other director's office positions, from the chief of staff and the chief medical officer, I think that really wanting to do a couple of things. I mean, obviously for me and for the agency, assuring that, like that the director's office has appropriate senior level representation, and also want to, for whoever comes in as permanent director, an opportunity to build their own team too. So it's a little bit of when is the right time to do this, Oscar, honestly, and just really wanting to empower the division directors that are there to help manage the agency as a whole a little bit, and help me and others in doing that. So I don't know if that's the right strategy, but trying to keep things going that way. And unfortunately, I do need to take off, Oscar. So
Okay.
appreciate your time.
All right. Thank you so much, Dave.
Bye.
Okay, well, I think we don't have any public input at this point, so we're gonna take our break next. It's 10:02, so let's go ahead and come back at 10:15. So we'll have a slightly longer break. So we'll come back at 10:15 and continue with the meeting. All right, let's go ahead and get back to our meeting agenda. If I can just sort of get a thumbs up from board members or put your video back on just so that I know that you're back and ready. Okay, thanks, John. Kirsten. Maybe we'll give it one more minute. Okay, so I believe Brenda will be joining us here pretty soon, and Melina had to jump off. So we'll go ahead and move on to our next agenda item, which is a presentation on the basic health plan. And we are going to use a good amount of our meeting time today to discuss this topic because we are headed towards a very important vote. OHPB will also be hosting an educational webinar on the Basic Health Program next Tuesday, July 18th from 8 to 9 a.m. to dive further into this topic. It's critical that members feel knowledgeable and prepared on this topic as we move towards a vote on the draft blueprint report at OHPB's September meeting. So I'll hand it over to Nikki Olson and Laurel Swerdlow, both with OHA's Health Policy and Analytics team, to kick off today's presentation. And welcome back, Laurel. Go ahead and take it away.
Thanks, Oscar. I'm going to kick us off today. I'm Nikki Olson. I use she, her pronouns. I'm in the Office of Health Policy as the Health Policy Development Manager. I'm a relatively new face here specifically at OHPB, as you've had Laurel and Tim doing a wonderful job representing this work to date. Just a bit more behind the scenes, but been working on this policy work since the beginning. So I'm happy to be here with you all today. And like you mentioned, thanks for having us back. This is really critical policy work, and we want to make sure it's also really complex that we're taking the time to walk through the details with you all so you can understand it better. As the board plays a critical role in approval of the actual basic health program blueprint submission as directed by House Bill 4035. So we're excited to update you all today specifically too, because we just wrapped up public comment period for the BHP blueprint, and we want to bring you some of that feedback here and talk through that in more detail as a part of your review. So as you would imagine, it's really important to us and to this process that you have a full understanding of that feedback that we've received. We've brought comments throughout the presentation today and created a summary. And we've also supplied you all with the full packet of all public comment. You'll note that the comments predominantly in support of the BHP. And the biggest concern among those kind of opposed to the BHP or thinking about some impacts involved with the BHP is to marketplace impact. So we've featured some quotes and some details in regards to that. We have an upcoming webinar on that. We did want to have a note kind of at the top that the quotes there's no quotes featured from folks who were opposed to the BHP. We did feature very specific quotes though about the marketplace impact that because they were articulated really well and encourage the state to continue to do this policy work to address the impact, which we also as a state value marketplace affordability and will continue to do that work. So we just wanted it to be kind of really clear and transparent about everything we received. We do encourage you to read all 5 of the public comments that were opposed, again, as predominantly many were in favor. So you have all those available to you. So with that big picture in mind, let's look at today's agenda. We can bring the presentation up. So on the agenda slide, you see that I'm going to kick us off by sort of centering us and reiterating the intent and value of Oregon's Basic Health Program. And then Laurel's going to take it from there and walk us through what's ahead for this work, the timeline, and how the vote fits in with all that context. And after that, as we discussed at last month's meeting, there's an important policy context that we've been communicating around the impacts to Oregon's individual marketplace that result from the creation of BHP. So we have a upcoming public webinar plan to go more deeply into those impacts. And we're going to reference and kind of center a little bit on that today, so folks are tracking. And then finally, as I mentioned, we wrapped up public comment. So quotes from that will be throughout the presentation, and a brief focused summary at the end will be provided. Okay, so next slide. So just starting out with the value of the Oregon Basic Health Plan, and on the next slide, starting off with the basics. So what is a basic health program? So section 1331 refers to the section of the Affordable Care Act that gives states the option to create a basic health program, or a BHP. It's essentially health coverage for individuals with incomes between 138 to 200% of the federal poverty level, or FPL, who would otherwise be eligible for marketplace coverage. States apply to create a BHP via submission of what is called a BHP blueprint. We apply to the Centers for Medicare and Medicaid, or CMS. Laurel's going to go into more detail about what is in the blueprint later. So once approved, states receive federal funding to cover the BHP population and run the basic health program. On the next slide, I'm kind of giving you just a very high overview of what is Oregon's BHP. We went through an extensive public process for making decisions about the design of the BHP through a legislatively mandated task force. That included multiple in-depth analyses around the level of funding Oregon would anticipate receiving from the government for this and what kind of program we could design with that funding. Again, Laurel will talk more about that later. But at a high level, when we talk about the BHP in Oregon, we have envisioned and designed a benefit that looks similar to the Oregon Health Plan. We estimate that over 100,000 adults would be eligible to receive these benefits at no cost to those individuals. And again, the plan is almost entirely federally funded. So what you see is the high level Oregon BHP is designed, and we're really thrilled that we can offer the BHP at no cost to members, as that can, as you know, be a major barrier to coverage and accessing needed care, especially for this population. Next slide. So taking a step back, let's talk a little bit more about the basic health program, who it's for, and why Oregon is pursuing it right now. So as I mentioned, it covers adults with incomes 138 to 200% of the federal poverty level. That's approximately 20,000 to 29,000 annually for a family size of 1, or 41,000 to 60,000 annually for a family size of 4. Obviously, the lower range being the 138 and the higher range being the 200% of FPL. And as you can see on the right on the diagram, from an income perspective, this program, the eligibility for the income, fits right between Medicaid and what would be the subsidized marketplace consumers that have incomes between 200 and 400% of the federal poverty level. Next slide. So it's important to understand a bit more about this particular population and what we know about their history with coverage. Looking at our Oregon Health Insurance Survey, this is data from 2019. So this is before the public health emergency, before the continuous coverage provisions were in effect for states. We have historically observed that those within this income range, 138 to 200, have lower insurance rates than folks who have Medicaid coverage or those who are in the 200 to 400 subsidized kind of counterparts to that population. So despite also receiving subsidized coverage on the marketplace, like the 200 to 400% group, this 138 to 200 has just had historically lower uninsurance rates. So that's the 82% versus 91 or 90. We see an opportunity here that this population needs a different solution to address having the same coverage rates as those who are in groups right below or above them. Next slide. So the graph on the right Just taking a moment to look at that, the initial plots are the ones you just saw, the 91, the 82, and the 90%. That's in 2019. So those were the insurance rates by income that we were just looking at. And you can see that for those in the 138 to 200%, we saw significant coverage gains from 2019 to 2021 when the public health emergency was in place and continuous coverage provisions were in place. That allowed for that group to finally be on par with the other groups in their insurance rates. So essentially, we know that continued access to no-cost coverage during the public health emergency improved rates for this group, and a BHP, in essence, provides continued access to no-cost coverage. And we saw this sentiment reflected in public comment, saying, we want to thank you and everyone working together on the OHP Bridge Plan and transition for those of us living always at the edge of our finances to our complex medical issues. Our lives were saved on many levels with OHP coverage during the pandemic. The next slide, there's a little bit more going on this slide, so we'll take our time and look through it. But essentially, the BHP is designed to help this population stay covered. So putting that all together, on the left is kind of our current state for this population without a BHP, and on the right, the diagram sort of provides a simple visual to help understand the shift that's intended with this policy to move this population eventually out of the subsidized marketplace coverage, which historically has resulted in lower insurance rates for this population, and to move them into the basic health program so that as their incomes fluctuate just above or below Medicaid, they remain in their CCO and provider network. We've noted this program is almost entirely federally funded, and this again is a moment to kind of the graphics kind of help conceptualize what's happening there. So essentially the federal subsidies that would have gone to this population on the marketplace now go into a trust fund, and that trust fund is what's used to run the basic health program. And the state can work with consumers and members of this program over time to design it to best meet the population's needs, and they use the trust fund to administer that. So again, as this was conceptualized by House Bill 4035, and then through this public comment process, we did receive comments that really reflected some of the intent of what we're trying to remedy with this policy. So on the left, we received comment that shared, well, it's possible that some can afford a qualified health plan on the marketplace or through an employer. Without a basic health program, many will be caught in the insurance gap. And in thinking about having the basic health program in place, another public comment they shared, I have so many more issues with healthcare access in the times I've had higher income and no longer qualified for OHP than in the times when I've had a lower income and qualified. It shouldn't be this way. So we're really trying to address kind of those fluctuations and the destabilization moving in and out of Medicaid coverage for this particular population. And in other words, kind of trying to prevent churning on and off of coverage. That's the term often used. So next slide. So simply put, the BHP is designed to help this population stay covered. And this sort of text from House Bill 35 really kind of recaps the intent well. It's to provide affordable healthcare coverage, improve the continuity of coverage and care, and reduce health inequities for individuals who regularly enroll and disenroll in medical assistance programs due to fluctuations in their income. So next slide. The basic health program has been an option for states for a long time. And why did Oregon choose to pursue this right now? Well, as many of you are aware, and we've already spoken to at the meeting today, is that during the public health emergency, which is now ended, we had some staying safely and stably covered on OHP due to the continuous coverage provisions. Now that the PHE is ending, we've begun the process of determining who is still eligible for OHP coverage. We believe there will be about 300,000 people who will no longer be eligible for OHP who have had that coverage during the PHE, but many of those will move on to other forms of coverage, and we want those who are eligible for the BHP to be able to roll over into that BHP coverage and stay in their CCO. It's really critical timing to provide that continuity of care for that particular population. And we've heard this kind of also reflected in public comment where somebody shared, we're also wanting to thank you for putting all the information out to help answer questions we had when we first learned we might lose medical coverage as the emergency funding ended. We have been living in fear and confusion, but documents like the basic health program, blueprint, public hearing we just read clarified a lot for us. In essence, for those already in OHP who qualify, we aim to keep them insured and additionally provide continuity in that coverage by having them remain in a CCO with that provider network. Next slide. So not only will this experience be stabilizing for those individuals, but it'll also preserve coverage gains that we've seen. It'll preserve coverage for an estimated 55,000 people who we believe will move from OHP into the BHP eventually. We have done some analysis and alternately believe that without a basic health program, we think that 20,000 or more individuals of that 55,000 would lose coverage during the Medicaid to marketplace migration process, which is really, again, at the heart of this policy, is to continue to have stable coverage. But we also estimate there are over 11,000 people who are currently uninsured that will take up this no-cost coverage when it comes into being. And we heard in public comment, any legislation or policy that extends popular access to programs like OHP is a net benefit for everyone on my caseload and gives young people I support just a little more room to breathe. I unhesitatingly support the extension of the PHE policies for Oregon. And we'll note this is not necessarily a literal extension of PHE policies or a literal extension of the Oregon Health Plan, but it is no cost coverage similar to the Oregon Health Plan for this population. On the next slide, kind of putting this all together over the next 2 years. So the basic health program is set to launch in July of 2024. Folks who are currently on the marketplace who qualify for it will migrate over to it over several years. But all in all, kind of taking a step back, the whole picture is that we estimate over 11,000 of uninsured people will become insured through the BHP. Over 35,000 will eventually migrate from the marketplace to the BHP, and the 55 that are currently in OHP who've had continuous coverage through PHP will be found eligible and eventually enroll. And we'll have over 100,000 folks covered through the basic health program. Next slide. So in summary, the BHP will prevent people from cycling on and off CCO coverage due to short-term fluctuations in income. Historically, we've seen as many as 34% of people who are enrolling in OHP that they were returning after less than a year. So really kind of seeing this as a consistent issue that we hope that this will help address. We also know that losing OHP coverage is the most commonly reported reason for being uninsured. And the cycling on and off coverage, again, is called churn and results in disruptions to care, worse health outcomes, and higher admin costs. Next slide. So kind of wrapping up, another sentiment similar to this in public comment was we appreciate the state's understanding that individuals who may access the BHP have an increased likelihood of moving in and out of eligibility for OHP coverage, and consistency with regard to benefits and provider network are beneficial to patients in terms of access and continuity of care. So I think this is a good place to pause. Laurel's going to go into more of the timelines around the vote, the other larger policy context that needs to be shared around impact marketplace and more info and public comment. But I want to make sure that there aren't any questions on anything I just covered.
Thank you, Nikki. Any questions from the board at this point? I have a couple just very minor, I hear these like almost entirely federally funded. What's the part that's not entirely federally funded? What's the gap and how will that be covered?
Laurel, Tim, would you like to speak to that?
Yeah, definitely. So under federal law, BHP trust fund dollars cannot go to administration, and furthermore need to be administered through a plan. So in our case, it would be through a CCO. There are some services that our state chooses to provide to OHP members via fee-for-service. And so there's a small bucket of services that we would like to continue to be able to provide in that manner. And so for those services, there was a small amount of general fund allocation in the 2023-2025 biennium for that purpose. But again, the vast majority of the funding will be purely from the BHP Trust Fund.
Well, how surprising that the federal government doesn't want to pay for administration. That's let's see. And then another question, Nikki, you say, this is a very similar program to OHP. What would be the biggest differences that consumers would experience?
The biggest difference is that it won't include long-term services and support. It'll be the CCO administered OHP services, which except for health related social needs, which we're still in conversation about. Laurel, Tim, did you want anything to that?
That's perfect.
Okay. Other questions from folks?
I have a question.
Sandy.
Yeah, this was brought up last week at a meeting I was at regarding long-term support services. So what options do individuals have? Because they may be eligible for the the basic health program to actually access those coverages. We know 30 days, 100 days with just Medicaid patients, Medicare patients, it's burdensome and it's expensive for people these days to have long-term support services. So what is Oregon or the Oregon Health Authority, now that Department of Consumer and Business Services is under your umbrella, looking at providing, because a lot of people are going to fall off. So, and those may be those ones that, meet those criteria. And then now elderly people will not have these services. So the outcome of it is going to be expensive and, burdensome on our patients.
Laurel, do you want to speak to that? We have looked into this more deeply to try to understand the impacts as a part of this process. So,
yeah, I really appreciate the question, Sandy. So, it just so happens that folks who are eligible for long-term services and supports have higher levels of threshold eligibility for OHP. So again, the BHP is for folks up to 200% FPL who would otherwise be eligible for tax credits. Folks who have OHP at these higher thresholds are not eligible for tax credits and therefore would actually be able to keep their OHP coverage and they wouldn't be transitioning into the BHP. Tim, please correct me here, but I think we've done a crosswalk and identified there's not really an overlap there or a gap between those two eligibility thresholds. Can you speak to that further?
Yeah, I mean, I guess I would start with just the clarity that I think that you were saying too, is like the creation of the BHP will not reduce access to LTSS from where they are now, right? There's nobody who like currently as Medicaid long-term services and supports from an income eligibility standpoint that we're going to move to this instead. This is there could be instances where folks' income has changed over the pandemic, and I think what Laurel's getting at is that the interaction between the income eligibility ranges for LTSS services and the BHP means that for the most part, folks who are getting long-term services and supports would not be moving into the marketplace, would not be moving into the BHP anyway. The piece that is sort of like in Medicaid but wouldn't be in the BHP. So somebody below 138 could have, and somebody in this range wouldn't, and they also wouldn't in the marketplace. There's a suite of services that's often referred to as the K plan, and I would need like ODHS experts really to dive into this more, but that was part of the Affordable Care Act and some expanded services for low-income Medicaid adults who maybe don't reach the full need for nursing home level care, for instance, and those are the services that are part of Medicaid below 138, but not part of the BHP, and similarly would not be part of what somebody could get if they went to the marketplace. One also note of clarification is that a lot of private coverage does cover like a very short term nursing home stay or something as part of rehab services and all of that, and that is part of the CCO benefit that for this group. So, and that's also often part of private health insurance coverage. So that sort of comparison covered service would be part of this program, in addition to part of marketplace plans. I don't know if that is more information than is helpful, but
No, I understand the K plan, but I'm just saying, so where would I find the data that you've done in regards to the basic health program and in regards to just long-term? I mean, this was brought up last week by the OHA director, so I'm just curious, where is that data that, you know, that I can look on OHA to find out more information?
Would you be speaking to kind of the analysis we did to say, when you look at the interaction of eligibility for those services and income, we actually will see that people will get the coverage they need for those services, that kind of analysis?
Right.
Yeah.
So, I mean, you've got to have that data, you know.
Yeah.
So
we don't have data on the specific individuals, but we can kind of share more about the analysis we did to ensure that this wouldn't create a gap.
And then I'd also say Section 8 of the Basic Health Program Blueprint outlines the services that'll be covered, and that speaks to some of the services that Tim was just outlining there.
We can follow up with that.
I just have one question. There was a new announcement with CMS and Medicaid in regards to making care primary MCP model. I know they're going to initiate that in Washington. Did Oregon look at that model at all? I know where yours is coming from back east. Your model is from Minnesota, I believe, the basic healthcare program. But I was just curious, when you were developing, you know, I know this is not happening right now and it's still in the process. Was that reviewed or not?
Can you say again which thing you're referring to? That it was reviewed?
The making care primary. It's MCP model. There's currently so they'll operate 10.5 years starting July 1, 2024. There's probably 10 states that are actually initiating this. Colorado, Massachusetts, Minnesota, New York, New Mexico, New York. North Carolina and Washington State. So right next door, they're initiating this new model. And I know we've looked at a lot of different platforms, CCO.2, CCO.3, just, you know, there's been so much happening over the last 10 years in regards to CCOs and a lot of their metrics that they have to meet. And this is just another version of Medicaid with CCO organizations. So I'm just curious, what other efforts has the state looked at in regards to different types of models be initiated?
So, oh, sorry, I see Troby's hand up, so I can hold, and if you want to go first, Troby.
No, you go ahead, Tim. I'll jump in after if we don't say the same, if we don't have the same thing in mind.
Yeah, I guess the one thing that I was going to note is looking at a little bit this model is that it's like a service delivery model, whereas the basic health program is a coverage expansion. This is a new population that is not Medicaid eligible, that otherwise would be served through the marketplace instead of through our CCO system. And so I don't think that the making care primary model incorporates this coverage expansion, this new eligibility category, in the same way that we're trying to use the basic health program to do.
Yeah, I get that, but so then is Oregon going to have their own platform? Are you getting off the marketplace exchange platform and moving it this way at some point?
So I guess I can keep going. There was a bill, the legislature did pass a bill this session to direct the state, to direct OHA to develop a state marketplace platform to be effective for the 2027 health insurance plan year. So to have it available at the end of 2026 for enrollment beginning January 2027. I think there's some level of separateness in terms of the pursuing a BHP doesn't rely on having to have that state marketplace platform. And so that's just a revision to how the state will serve folks. If there is a BHP, how the state will serve folks over 200% of poverty, whereas this group, the 138 to 200%, would stay in the CCO system. But so yes, there is an effort to have a state marketplace.
Could I jump in for a moment, Oscar, to try to respond a little bit, Sandy, because what I hear you saying is, hey, this model is really intriguing, this Making Care primary model, and has Oregon taken a look at it? And what I would contribute to the conversation here is that the BHP and this model for primary care are not mutually exclusive, right? And that Oregon is doing a lot of work around primary care, patient-centered homes, and has been in close conversation with CMS, who is really using a lot of the components of Oregon's model in what they're rolling out nationally. You know, there's a lot of support for what we're doing. And what we could do to follow up is invite some of our colleagues who are working closely on those models in to talk to the board and get a sense of, you know, the Making Care primary model in particular, and which aspects of that are really reflected in the way Oregon is moving forward. I know there's a lot of folks who are really excited about the model that has been developed for primary care in Oregon. There's been a ton of work, and understanding how that might fit some of the FQHCs and Indian health programs is really important, but I don't think we quite have the right crew here today to speak to that for you. But it's not mutually exclusive from a basic health program in any way. Does that help?
Yeah. I was just curious, you know, Oregon's been pretty, they've moved really well and been progressive, you know, through CMS and I just think we've always been innovative, you know, looking for models that fit Oregon. So I appreciate that.
Great. We'll follow up on that.
One thing I'd love for the webinar next Tuesday is if there's a little bit more of a further explanation or focus in terms of like long-term services and support, and really what that means. Like, I want to understand, you know, what are those services that folks under the basic health plan wouldn't be eligible for. And I'd also like to know more about, you know, the portion of money that the state is going to cover that's not going to be covered by the federal government. I'd like to know more. I mean, it sounds like there's already a plan right now for the next couple of years because of the investment that has been made. So I'd like to know what is the, you know, plan after the next 2 years as well. But I think we can kind of keep moving through the presentation. Go ahead, Laurel.
Hi, everyone. My name is Laurel Swerdlow. I use she and her pronouns. I serve as the project lead for the Basic Health Program. So let's pivot here to talk a little bit about the timeline for establishing this new program and the role that you all will play in this process. Next slide. So the process began in 2022, as Nikki was saying, with the passage of House Bill 4035, which directed the agency to administer a permanent program for this population. It additionally directed the creation of a task force, which provided recommendations for the program itself, which I'll talk about further in just a second. Last fall, OHA applied for an 1115 amendment to temporarily expand OHP up to 200% FPL while we finish developing the permanent program. This waiver was approved by the federal government, and the 2023-2025 biennium budget included sufficient funding to implement this temporary expansion category, which was exciting to see. And over the course of the past 6 months, OHA has been developing the BHP blueprint, which was submitted for public comment and tribal engagement beginning in May. Public comment ended July 1st, and I will be talking through an overview of the comments we received later in this presentation. Ultimately, you all will be voting on the final blueprint before it's submitted to CMS. Last month, we flagged that your review would occur in August. We checked in with Oscar and Kirsten and realized that because the August meeting will be in person, it's going to focus on community-based priorities. So you're instead going to be finalizing the blueprint at your September meeting. The review process for blueprints isn't nearly as robust as the process for waivers. CMS has requested blueprint submission 4 months before implementation, so we anticipate final approval sometime in the early part of 2024. And then finally, as Nikki noted, the BHP will go into implementation in July of next year. Next slide. So as I mentioned, House Bill 4035 directed the agency to administer a permanent program for this population. The bill calls out, and the task force reaffirmed, that the program should be administered by CCOs with no cost to enrollees, covering the CCO delivered OHP service package. The task force recommended that the program begin with capitation rates that mimic OHP rates, with rates growing over time as the trust fund grows to enable higher than OHP provider reimbursement in the long run. And then lastly, the bill and the task force directed the state to explore strategies to minimize the impact that this program may have on individuals who remain in the individual market with incomes 200% of the federal poverty level and above. We'll talk more about that later in this presentation and then again next week. Next slide. So the task force created by House Bill 4035 met 14 times last year. It included representation from CCOs and carriers, as well as low-income workers and health equity experts. Kirsten was a member, along with Stephanie Caballero, who represented OHPB. A summary of the task force's recommendations is included on this slide. I'm not going to read through this list because I mentioned almost all of these points in the previous slide, but a key thing to call out is the task force recommended that the state pursue a Section 1331 basic health program as the federal authority to administer the program outlined in 4035, a program administered by CCOs, covering the CCO administered OHP service package, no enrollee costs, and capitation rates that eventually enable higher than OHP provider reimbursement. Next slide. So given that the CCOs will serve such a critical role in administration of the basic health program, OHA has been keeping in close communication with CCOs over the past year. One of the ways we've been doing this is by hosting a now monthly CCO table. The purpose of this table is to meet with CCOs to solicit feedback on plan design, identify operational issues, and develop solutions to ensure successful launch of the program. The roadmap for this table was co-created with CCOs, prioritizing those topics that they deemed most important. The meetings that have been held to date are listed on this slide here. As you can see, conversations have really ranged in topic. We've discussed investments in social determinants of health, questions about value-based payment and quality pool, and then most recently, we covered the MMIS system build and the treatment of directed and supplemental payments. Next slide. So because you're going to be playing such a key role in finalizing the blueprint, we want to remind you a bit about the process for developing the substance here. We convened ODHS and OHA interagency drafting teams in January and February to walk through each section. And both agencies, as well as you all, reviewed the draft before it went out to public comment. But it's important to note that we didn't draft this blueprint from scratch. As I've noted, we had the recommendations of the task force to rely on. Additionally, we were able to refer to Minnesota's application throughout the process. Minnesota's the only state that currently administers their BHP through their Medicaid managed care entities, so their blueprint served as a helpful reference. And then lastly, our goal has been to align BHP processes with OHP processes in order to minimize administrative burden, both for the state and for CCOs. So for any outstanding questions that remained, we were able to refer to OHP processes and structures in an effort to avoid duplication of efforts. Next slide. So as a reminder, the blueprint has 8 sections that are listed here. It provides really just an opportunity for the state to attest compliance with various BHP federal requirements related to eligibility, enrollment, operations, and benefit coverage. What I'll note here, and what I've said before, is that the state is used to the 1115 waiver process, which is a much more robust process than the one for the blueprint. The blueprint is a 29-page document, and much of the substance are tables with attestation checklists. So it's a shorter read than some of our more detailed waiver applications. Next slide. So just to reorient ourselves once more before heading into the next section, this timeline provides a really high-level overview of where we are and where we're going. The temporary Medicaid expansion category began in April when redeterminations began. So as individuals undergo redeterminations, folks who are 130 to 200% FPL continue to be eligible for OHP, allowing them to stay on their CCO coverage while we get things ready for the BHP launch. We'll be submitting the BHP blueprint to CMS in September and anticipate approval sometime early next year. And finally, the BHP is scheduled to launch in July of 2024. Next slide. So now let's talk about some key policy context focusing on marketplace impact here. Next slide. So we dove into the weeds a bit during last month's presentation on this. So we want to zoom out today and offer a higher level summary here. Launching a basic health program will impact enrollment and affordability of private plans on the individual marketplace. Due to current federal marketplace policies, we've recently learned that this impact will actually occur gradually over 3 years, as opposed to all at once. Oregon has done extensive research on this impact and examined several approaches to mitigate it. After 18 months of discussions with CMS, we've concluded that there are no viable federally funded solutions without a state-based marketplace. Next slide. So on July 18th, there will be a dedicated OHPB educational webinar to talk through this critical and complex part of the work of House Bill 4035. OHA and DCBS are committed to continuing to work with carriers and legislators on solutions to improve marketplace affordability, which continues to be a top priority for both agencies. Nikki spoke to this at the beginning, but I'll reiterate that we chose to quote concerns voiced regardless of source here, because some of the most compelling articulations of this concern came from organizations that were either neutral or in support of the BHP rather than organizations or individuals described as opposing the program. So the comment here we felt really captured the concern that we're working to address. The comment reads, the agency has very recently communicated in various fora that it believes that for plan year 2025, approximately 30% of enrollees will experience premium increases larger than $25 per member per month. We may be supportive of the blueprint in general, and we always understood that the adoption of a basic health program blueprint would create some level of premium impacts. Nevertheless, given the late information before us, we urge the Oregon Health Authority to collaborate closely with the Department of Consumer and Business Services to seriously address this potentially looming impact to health insurance premiums. Next slide. So as Tim noted, the recent legislative session further expanded Oregon's ability to improve marketplace affordability with the passage of SB 972, which directs OHA to implement a state-based marketplace or an SBM by plan year 2027. Unfortunately, as I just noted, options are more limited for 2025 and 2026 without an SBM. But OHA is continuing to explore all possible opportunities, and we'll discuss these further at the July 18th webinar. Another quote that speaks to this concern is captured here on this slide. It reads, also, while a smaller population than those who would benefit, we are concerned for the financial impact on the estimated 11,500 people who would see their monthly premiums increase by $100 to $200 by plan year 2027. While this population will be earning double the income of those on the BHP, we recognize that increases of this size can still put people in financially precarious situations. During the years leading up to Plan Year 2027, we urge OHA to identify and pursue additional strategies to mitigate these large premium increases. Fortunately, there is time, and we believe the agency, DCBS, and involved stakeholders possess the expertise to do so. Overall, we remain excited about the development of a basic health plan and its ability to positively impact Oregon's insured rate and the health of low-income residents of our state. Next slide. So throughout this presentation, we've provided quotes from public comment, and we wanted to dig in a little deeper into the range of public comment we received. As Nikki noted at the top, a document which compiles all of the public comment we received is included as part of your meeting materials, and so we encourage you to take a look. Next slide. First, an overview of the process. The public was invited to submit verbal and written comments on the draft blueprint from May 1st through July 1st. Verbal comments were given at 2 public hearings, one on May 9th, which was a BHP specific meeting, and another on May 31st, which was part of the Medicaid Advisory Committee meeting. Written comments were additionally submitted via email and snail mail. Next slide. A total of 41 individuals and organizations submitted public comment listed here. You'll note we received comments from CCOs, insurance carriers, advocates, providers, as well as members of the public. So we were really pleased to see such a range of engagement. Next slide. So this slide attempts to capture a high-level summary of the comments we received, which of course was challenging given how rich the comments were. So again, I encourage you to read through the comments themselves. But at a high level, of the 41 individuals and organizations who submitted comments, 35 were in support, 1 was neutral, and 5 were against. Thematically, we saw general support for the BHP, support for the BHP going even further to cover individuals up to 400% FPL, support for a state-based marketplace, and support for various payment methodologies and the need for sufficient provider reimbursement rates. And we also saw concerns regarding those increased costs for marketplace members, concerns regarding communications and administrative burden related to the mid-year launch, both of which again will be discussed in greater detail at next week's webinar. I want to especially highlight here the comments that were received from consumers. We received a couple comments from some very passionate consumers, one objecting to expanding public programs generally, and one concerned about consumer choice, but the majority were in support and expressing excitement about the program. Next slide. Next slide. So we've talked a lot today during today's presentation about next steps that you all will be taking and reviewing and finalizing the blueprint. We want to make sure to also highlight next steps between now and the launch of the basic health program, specifically talking about our focus on communications and partner engagement. Over the next year, OHA will continue to engage CCOs during our monthly CCO table. We're additionally planning to revamp our carrier table, which we'll discuss further again as part of next week's webinar. And of course, we'll continue to engage community partners and BHP eligible consumers. We've stayed closely plugged into the redeterminations process so that our partners know that this new program is coming down the pike. And we've been presenting regularly at both the MAC and the HIMAC meetings so that we're engaging groups who currently serve BHP eligible folks coming from Medicaid as well as those coming from the marketplace. And we'll continue to build out a communications plan to make sure we're able to successfully reach all 3 populations that we anticipate transitioning into the BHP. And with that, I think we're ready to open up for more questions.
Thank you so much, Nikki and Laurel, for your presentation. Let's see, it looks like Sandy has a question.
Yeah, just a quick question. I was reviewing, insurance carriers, and Care Oregon merged with a California-based company. So when that occurs, I guess, out-of-state individuals coming in, or well, it's usually out of state anyway, but those mergers, hopefully the care will be better. There'll be, more services, eligibility for individuals. But when is that discussed with the Oregon Health Policy Board for those type of mergers, and how many occurred this year? you know, there were a lot of LLCs involved. So I just curious. I did some background on that, so I'm just wondering how many mergers took place this last year.
Yeah, and then, so I think that might be a better question for Trilby, who already has her hand up. So let's, because it's part of the HICMO program, and we do get some attachments to included in our board packets. I would say that there isn't a great way that the board, is hearing these like regular presentations or updates as of now. It's felt that way, but we do get attachments where there's links where we can, as board members, get ourselves much more engaged. But let me have Trilby answer that.
Thanks, Oscar. Sandy, you are really asking these challenging questions that connect all the dots across various programs at OHA. I really appreciate that. And once again, would have to say that in terms of the actual transactions being reviewed by HICMO, that is our healthcare market oversight program, that is not really something that other staff can speak to in public settings. We have to be very careful with the review of those interactions, those transactions, and follow the process that's set out in statute. And that is part of why, Oscar, there's not a special process for the board to comment and be involved in any decision-making with HICMO. It's a very tightly prescribed program. So we are providing you with the updates that the program releases, and those are in your packet, and you can take a look there. And you'll see that the merger that you referenced has not happened yet, but we can't really share a whole lot more information at this point because it is under review. But I do very much appreciate the way you're connecting these dots and reflecting on what the future might hold in terms of changes in CCO ownership, which I think is a wonderful topic for the board, and would, of course, impact the BHP since it is delivered through CCOs as well. So I'm sorry not to be able to give you more specific information there, but would encourage you to take a look at the packet that you have with your materials.
Okay,
Let us know if there's more you'd want to know after that.
Yeah. I was just looking, at some information, so I was just curious about how that takes place. So thank you.
You bet.
Let me go to Brenda and then John before we get to you, Ali.
Thanks. And I just first want to comment, Nikki, Laurel, Tim, your presentation was really excellent. It takes a really complex program and puts it into pieces that I think are really digestible. So I really want to thank you for the layout and the work that you put into it. My question, and you can turf this to next week's webinar, or which unfortunately I cannot attend, but I will watch. It's really around kind of some of the nitty gritty in terms of the comparison between the CCO benefit packaging and what will be available for the basic health plan. So some detail under that. And simultaneously, the question about like, are we making assumptions about the health of this specific population? Do they fare better or worse than existing CCO populations, the populations that are currently on the marketplace? And so a little more detail on what we know about the quality of their experiences in the healthcare space, plus their sort of state of disease, I suppose. And then my last question is really around the rate setting process for this population. So how the funds flow to the CCOs, and are there potential risks to the CCO contracts, or do the CCOs generally think of this as a good thing relative to their financial health and well-being? So 3 kind of somewhat related, but a bit different questions. And you can take any of them now or turf them all to next week. I'm happy either way.
I think that we can at least take them at a high level right now. I think, and we have some materials, so trying to remember each of them in order. The first one is really the benefit package. And we do have some materials that was put together for the task force when we really tried to dig into this and like what is covered by marketplace plans, what's in the CCO benefit package, and how do we comply with the essential health benefits requirements of the ACA. And there really are just a handful of services that are not delivered through CCOs that are, OHP services that won't be included in here. And, Laurel mentioned the LTSS services. The other bucket is health related social needs, which are still getting rolled out from the new waiver, but that's not being included in the short term for the BHP. But I do think we can get some of those materials that we put together for the task force to really help define that more clearly, and really the work that happened to crosswalk the way that services are defined in the commercial world for the essential health benefits, and then the way that services are defined in the Medicaid world in our state plan. The language doesn't always line up, and so there was a lot of work to really put those together and see, we call it this in one bucket and we call it something else over here, but really it's the same thing. And so we have some of the work that went into that.
Can I add something real quick, Tim?
Yeah.
I think something just to kind of big picture context on this question is that the basic health program, sometimes we talk about how it's called basic, and that's not very alluring, but really the service package that the task force has recommended and what we are preparing to implement is really robust relative to the floor of a basic health program. So we were really excited when the results of all of our analysis were no cost to enrollees and something that mirrors OHP. So just to offer the context relative to what a basic health program floor is, we have a really robust service package.
Yeah, I was going to say something similar, just to reiterate that the ACA kind of offers this floor for what states can provide, and that's why it's called basic, because they have these essential health benefits, and that's the floor. But the crosswalk that Tim's referencing really underscored that our OHP, the CCO administered OHP service package, is much more robust than what's outlined in those essential health benefits.
And just to note that one, I think, very notable service, for instance, is the basic health program will contain the OHP dental benefit. And dental is an add-on in the marketplace. People can buy dental coverage, and maybe some plans would come with some, but the full dental package that's available for OHP will be part of the basic health program. And the second question was about the populations and for lack of a better term, maybe the morbidity and comparing this group to both sort of Medicaid and the marketplace. And with the caveat that some of this analysis is tricky, right? We don't know everybody's current income because of the pandemic, because of the continuous coverage provisions. But some analysis was done by our actuaries to really look at some characteristics that we think are associated with people likely higher income, or maybe with folks who have stayed on longer on Medicaid than normal anyway, to try to get a sense of who we think within the overall Medicaid population is the likely BHP cohort, and then to look at their claims, their health status, their risk scores to when available. And I think also looking at the experience of Minnesota, this is a less expensive population than the Medicaid expansion population. And some of it is just, income related. It's a higher income population, and there's a lot of correlation, if not causation, between income and health status. And so from that standpoint, it is likely a less expensive population than the under 138 Medicaid adults for which this is sort of a subset right now, in terms of who's on the market or who's in OHP. And similarly, we can look at the 138 to 200% population in the marketplace, and there was some comparisons of some of the risk score data there to what we saw in OHP, and I think that further sort of like confirmed, or at least lended evidence to that conclusion, that the risk scores, quote unquote, for that 138 to 200% group on the marketplace backed up the idea that it's a slightly less expensive cohort than the under 138% folks who are in OHP. And so that analysis was part of the feasibility analysis in the fall presented to the task force, from the actuarial analysis presented to the task force to say, can we afford this service package with no co-payments? And that conclusion was yes, within the federal funding formula that will be available to us for the BHP.
I can quickly speak to the last question to give you a second to breathe. If that's, do you have the
sure.
last question?
Yeah, no, go for it. Go for it. Go for it.
I mean, at a high level, Brenda, we're there's going to be a separate contract for the basic health program. And in the long term, we're still figuring out how this is going to be sort of incorporated into the broader procurement process, but there will be a sort of a third BHP specific contract. And there will be BHP specific rates. And the CCOs can go forward kind of with providers and think through how to be contracting with providers accordingly. Does that sort of at a high level speak to your question on contracting?
Yeah, that's great for now. Thanks. Yeah.
Let's go to John.
Well, I have a few comments. First of all, I want to say from the outset that I haven't seen anything since this discussion started 2 or 3 years ago that would keep me from not enthusiastically supporting that this move forward. Hundreds of thousands of people are going to benefit with the overall approach that the state is taking. And the concerns that I see expressed primarily by commercial insurers, I don't think should stop this process. Second, this is a perfect example of the mess that occurs when you try to finance health through an insurance model that involves risk. That means you have to take into account the behavior of large organizations whose goal is to preserve themselves, understandably, and then the behavior of an incredibly large portion of very vulnerable people. It's crazy we're doing this. It is crazy we're doing this. And there are other ways to do this. Imagine if this was a budget model and not an insurance risk model. So there are some things I think that would help me in the next week or so. The first is I think we have to own up to a bit of a process issue here. I wish, the Marketplace Advisory Committee is one of our committees, right? I would like to hear, well, what do they think? I don't think we have a board liaison to that committee. We should. And when the board gets populated, I hope someone is the liaison. Because my suspicion is that the sense that some of the folks on that advisory committee have of this would be useful. I don't know if we can identify recordings of meetings where they have discussed this. And for myself, I'd probably try to listen to those because it would help me maybe understand, especially the mitigation issue. I mean, the focus is on the mitigation issue. Laurel, as you might expect, I'd love to see the portion of the Oliver Wyman analysis that explains, why they think this is going to happen. I mean, Tim, I think, has just, started that explanation. So this is based on a model. They built a model based on a variety of assumptions. That's what actuaries do. This is based on a model. They've had to build in a variety of assumptions to build that model. And that involves especially the behavior of a higher risk, lower income population versus a higher income, presumably lesser risk population. While I don't think any of us would have the expertise to seriously challenge the actuaries, actuaries aren't always right. I've had many experiences in my own life where they were not right at all, and they would be the first to admit it. So there's a degree of uncertainty here. For myself, I'd like to understand that a little bit, if that's possible, in terms of their description of the model and the reasons why they, think that this premium increase in the higher income populations would occur. Finally, those of us who've been insurance, there's wins, losses, and ties, and they happen all the time. And part of that business is balancing and managing those. Look at all of the things that the state is already doing to mitigate what really could have been an insurance disaster. The temporary Medicaid expansion, which the legislature just funded, as staff said. That's mitigation. That's pretty serious mitigation. Look at the federal funds that are coming in via the waiver that will include covering, children to a higher age, covering pregnant women, high-risk folks. That is an incredible mitigation. Is it a mitigation for this specific little population? Maybe not, but for the whole, it just bothers me to hear organizations who have reserves, they have a variety of mechanisms to survive risk, express concern. And now I know behind some of their comments as well, we're expressing concern. We know the state has done a lot, but we're all in this together. And I think both the exchange and OHP is a good example of that. Again, it does go back, ironically, to Dave's comments earlier. I think Healthy Oregon is infusing $500 million. Is that the total cost of that program? I think I recall that from the legislative discussion. That's pretty interesting mitigation that downstream, should reduce provider reimbursement, because now all these previously uninsured folks are covered, all of those sorts of things. So, there's a bigger picture that just makes me feel the emphasis should be on moving forward. Yes, there should be some mitigation here. Everybody should constructively sit down and figure out how to not interfere with the timing of this in such a way that the folks who really need it don't get it, and we move forward. So that's where I'm at.
I just want to say thank you so much for your comments, John. And I think some of what you just shared will help guide the content we develop for the webinar on the 18th. And we can speak to the way the actuarial analysis, which is a very sophisticated, interesting, fascinating way of understanding and predicting people's behaviors in these situations. And we can get into a little bit of what we've learned through that process. And again, a lot of time and resources went into understanding this and continue to go into how to make the marketplace as affordable as possible for folks. So a value we have and will continue to drive towards, and we'll make sure we inform you all with as much detail as we can about kind of what information we have at our fingertips to make these decisions. So thank you for your comment to help guide that. And I also wanted to make sure folks were tracking that throughout this whole process. We have been meeting with the Health Insurance Marketplace Advisory Committee to provide these updates in detail. So just so folks are tracking, getting into the weeds on the actuarial analysis, the findings, the impact, having those discussions with carriers in those public settings has been going on throughout the process.
I have a question about engagement. So looking at your slides, you sort of have the, the draft blueprint being developed, and then public and tribal engagement happening, and then the vote occurring right after that. So it feels like, my question is like, how does that public engagement and community engagement and tribal engagement actually influence how the blueprint is, is changed or evolves right before the vote, and up until what point can that blueprint continue to be modified and evolved?
A good question. So to the first part, I think is more straightforward. So at a high level, we've been combing through the comments and both received written and verbal comments in the public comment side of things, identifying if there are any changes that can be made to the blueprint. A lot of the comments were more broadly about the policy context of implementing the basic health program. We didn't receive a lot of comments that spoke specifically to the substance of the blueprint itself. We have yet to identify any specific comments that would warrant changing the blueprint. There's still, within the next month, we'll be sort of finishing the process of identifying whether or not there's anything coming out of any of the tribal engagement conversations or the public comment that would warrant changes there. In the long run, we are always welcome and allowed to update our blueprint. We've seen New York change their benefit package as their trust fund builds. And that's something that we certainly could consider doing. So the blueprint is sort of a living, breathing document that can change over time. I'd be curious, Tim or Nikki, if you guys have anything else to add.
That was a good overview of that process. I think I want to make sure that it's just said really directly in regards to the marketplace impact and the ongoing conversations there. We do hope that there are some additional conversations that we're planning to have with carriers to go into more ideas. We do hope something more can surface and we can really push towards solutions for 25, 2026, and ideally with much more on the table for 2027 when we would have a state-based marketplace. So I just want to make sure it's said really clearly here that in pursuing marketplace impact mitigation, according to the bill, we really ran into significant barriers in being able to draw down federal funding with the limitations of not having a state-based marketplace. Because marketplace affordability is important, and because we think the basic health program is important, and we see these as moving forward together in kind of doing the best we can for all folks in Oregon, it's an ongoing conversation, and we really hope some more things surface. So having a vote in September obviously makes us be able to have more time to pursue those solutions in tandem with all the good feedback we're receiving on the direction we're going.
And Nikki, it's such a great point, and I'll then kind of reiterate that a lot of that work can continue on even after submission of a blueprint, because none of it would really be captured in the blueprint itself. It would be sort of a broader policy conversation.
Okay, let's go with Kirsten and then Sandy.
I support a lot of the comments that my colleagues have made, and also believe that this is a very positive step forward for the health of so many in Oregon. I'm excited about it. Nikki, I really do appreciate the comments that you just made about that effort around those mitigation strategies, because while I am like, yes, let's do this, let's take this step forward, this is important to do, I also believe that those mitigation strategies are pretty important because our health system is so annoyingly complex that while we're trying to fix this problem, we create some ripple effects in other areas that we then need to address, and so on. Fixing a falling apart system is challenging in and of itself. But so in the webinar, which I am sorry that I also will miss, but will watch, I guess I want to underscore like strong support for this effort. And also that when you are able, I think it is helpful to update this board on those mitigation strategies. And I recognize that that webinar, you're probably not going to have, I mean, I know you've gone through a list of things already, so I'm not asking for you to be like, here are our 4 ideas that we are pursuing at that webinar. But I think it is helpful to reassure the board, but the board in so much as it is a public space of reinsurance of like, this is the staff we have dedicated to it. These are the agencies that we're working with, because this is not an OHA pursuit alone. So I appreciate that you're like talking with insurers, talking with DCBS. So anyway, just basically what you did with slightly more detail of like this, we are pursuing these mitigation strategies. This is the team we have working on it. And when we have them, we will come back and discuss them.
Great. I know we're running out of time, but I saw Sandy's hand go up.
Just a quick. So with the ACA and the Marketplace Exchange, tribal organizations were able to have contracts with CCOs for insurance. This is the basic health program. Is that still going to be available? Like, the 138 to 200%, that's, I feel reasonably that some individuals will fall into those ranges. And we just had consultation with the 9 tribes last week. And so, but I didn't even think about that. So I was just curious. I know that you don't really focus on the 9 tribes, but we are government to government, and we have a relationship that, that actually, when CMS does approve this stuff, did you consult with the tribes? What were the comments? So just curious.
Thank you, Sandy. Looks like Trilby might be.
Yeah, thank you, Oscar. Sandy, OHA certainly honors its partnership with the 9 federally recognized tribes in Oregon as a government to government relationship. And on any issues where the tribes request formal consultation, we would do that at their request and on their timeline. And we would refrain from commenting on, the strategies discussed at those formal consultations, and really in any public setting, and really encourage folks who are interested, particularly members of the media, to contact the tribes themselves to hear about those formal consultations. And I appreciate very much that you were there and that you're up to speed on this. And I know that our tribal affairs director would want to talk with you about any questions you'd have about next steps out of that consultation. The specific question that you asked about whether the tribes could continue to contract with the CCOs for this expanded population that'll be in the BHP, the answer to that is yes, right? The CCOs contract with the tribes for the OHP enrolled members, and the same could happen with the BHP members who are participants who are enrolled through CCOs. So I can address that narrow question, but I just want to be very careful not to tread into the territory of the tribes.
I was just curious. It just didn't come up last week. So I just thought I'd ask just how that would, thinking about PPH and the Marketplace Exchange and working with fee-for-service and Medicaid Oregon Health Plan individuals in the CCOs, it just came forward. So I thought I would ask that question.
Yeah, and for those that are enrolled with the CCOs, it'll operate just the way it did with OHP.
I did find it curious that, out of the 45 public comment sort of, entities or so that we saw, there was no public comment from any of the tribal governments. So I am very curious about what have we heard from the 9 federally recognized tribes in Oregon about this program and generally supportive of it, or what their thoughts are. So it'd be good to hear more about that. Are there any other questions or comments from the board at this point? All right, well, a webinar next Tuesday. It will be recorded for those who can't attend. So 8 a.m. So please make sure that you can come and join and ask more questions. Thank you so much, Nikki, Tim, and Laurel for the presentation today. It was definitely a presentation that was much more accessible for the board to be able to engage in than last month. So thank you so much for all your work, and we look forward to seeing you possibly next Tuesday. So, all right, and up next, we have an update from the government relations team about the 2023 legislative session. And I know it was a very particularly challenging session, so really excited to hear from Ashley and her team about all the great work that they did. So sorry to shortchange you a little bit on time, Ashley, but
that's okay.
Yeah,
we will
excited to hear from you.
Great. Well, thank you so much for having us here to provide you an overview of the new OHA investments and key bills passed this legislative session. As many of you who've been following along know, this was a topsy-turvy wild session. The Oregon legislature introduced an impressive 2,970 measures, so more than any other session in the last decade. And 653 of them passed, many at the very last minute. And 22% of those were, that's about 22% of the measures that were introduced, and over 100 of them directly impact health or the work of OHA. So a little bit later, I'm going to go through the key investments first, and then Kaz and Phil are here from the government relations team to cover key bills passed this session. So if we could pull up our slides, that would be great. All right. Thank you. All right, next slide, please. So I want to ground us again in our OHA legislative goals for 2023 that you have seen before, and I'll zip through these. So to eliminate health inequity by 2030 by building health equity infrastructure. This is our key goal related to our primary goal of eliminating health inequity. So knowing that we need capacity within our OHA team, and then to support community partners related to public health and healthcare system towards that goal. Our second goal is around protecting the gains and continuing to expand healthcare coverage related to the basic health program and implementing the 1115 Medicaid waiver. Goal 3, stabilizing and enhancing the behavioral health system, really ensuring that the recent investments made in the 2021 session, the historical investments, that we're able to maintain those and build in new investments to continue to develop that behavioral health system of care that we know we need in Oregon to meet the needs of people who are struggling in our state. We had a goal also around focusing on the Oregon State Hospital operations, which is connected with our larger behavioral health goal, of course, working closely on legislation developed with community mental health providers, judicial experts, and others as we support the patient population served by the Oregon State Hospital. A key goal of ours was also around strengthening a post-pandemic public health system as we prepare for natural disasters, any future pandemics, as well as addressing reproductive health, prevention of chronic disease, suicide, opioid use, alcohol use, and other really key public health issues, along with counties and tribal governments and CBO partners. And then our last goal here is connected to the policy goal of promoting and partnering on housing access. That's a key goal for Governor Kotek in collaboration with our partners in the Oregon Housing Community Services, as well as community partners working in housing around the entire state. And that's very much connected with the 1115 waiver as well. Next slide, please. All right, so getting into investments. So overall, the OHA budget for the 23-25 biennium is $35.8 billion. It's an increase of approximately 6%. So the total number of positions in our agency is going to increase to 5,664. So even with the significant administrative reductions that the agency experienced and elimination of vacant positions. So we did see an overall increase. Our primary budget bill is Senate Bill 5525. If anybody wants to dig into that, there's a lot of detail there, and then investments came through other legislation as well. So the first investment that you see here is 15.7 million. This was a fully funded policy option package related to the race, ethnicity, language, and disability and sexual orientation and gender identity implementation. So ensuring that we can fulfill legislation passed in previous sessions to collect data and to really meet those requirements so that we can start to better understand inequity in our state through data collection. Although we were not funded for a key policy option package around eliminating health inequity and building in our internal infrastructure, we were able to swap out vacant positions to fund 6 key positions within OHA's Equity and Inclusion Division. So with this additional investment, we're going to be able to strengthen our diversity, inclusion, training, civil rights, and universal accessibility programs. So we received an additional $400,000, and then we're able to also swap out positions. We received some fund, 1.9 million to fund 10 positions at the Oregon State Hospital to enhance equity for patients there. And then a smaller investment of 2 million to supplement healthcare interpreter services. Next slide. So it was mentioned earlier, one of the very key investments and a really exciting advancement for Oregon is that the budget provides $563 million to provide full Oregon Health Plan, medical, dental, and mental health benefits to income eligible state residents, regardless of immigration status. So this is very important investment. It went live July 1st. Prior to this expansion, adults aged 19 to 25 or 55 and older were eligible for Healthier Oregon coverage, but as a result of this funding, it closes the gap for an additional 40,000 people, a really, really important health equity advancement. We also received $138.5 million in general fund to support the implementation of the 1115 Medicaid waiver. And when you match that with the federal match, which you'll see here of $923 million, you can see that that is quite significant to ensure that we are able to move forward this groundbreaking 1115 Medicaid waiver for continuous health coverage for children through age 6, extending coverage for everyone up to 2 years over the age of 6, and many, many other health-related social needs services that I won't get into today based on time. Another key investment that you've just heard about and talked about with the basic health program, 110.2 million of general fund. This is connected as well with the temporary Medicaid expansion funding that's needed to carry people along until the basic health program can be launched. So again, this signals to us that legislature is very much invested in the launch of the basic health program by fully funding this policy option package. And then last here, there's a 2.1 million investment of other funds for the marketplace transition from the federal platform to the state-based marketplace. You'll hear more about Senate Bill 972 from Phil a little bit later, which requires OHA to move to a state-based marketplace by November 1st, 2026. I see a hand up, so I want to stop for a second and see if Trilby has something to add here.
Yes, thank you so much, Ashley. Just a quick point of clarification on that 59 positions that you all see there for a basic health plan. Since we've just been talking about that program, I just want to clarify that this also reflects positions for the redeterminations effort overall. So it's not just BHP. Thanks,
Thank
Ashley.
you for that clarification, Trilby. Appreciate that. All right, we can move to the next slide. So getting into the investments for behavioral health, you know, I mentioned this in the beginning, but it's important to reference that the initial 1.2 billion in investments that were made in 2021 were maintained in our budget. And what we're seeing here are the additional investments to support our goal and Governor Kotek's priority to reduce deaths from unmet behavioral health needs, to disrupt the pipeline from untreated mental illness to homelessness to hospitalization and jail. So the key investments here represent a 7.4% increase from the 2021-23 budget. So first, we received $50 million in lottery bond funds to expand residential treatment beds for people with severe mental illness and expanding that acute psychiatric facility in the community. We received a limitation. This is a little more challenging to describe, but it's a limitation of $40 million to pave the way for additional opioid settlement funds if the Oregon Settlement Board makes the investment. And that would be to support life-saving overdose prevention efforts, such as the distribution of Narcan or naloxone kits across Oregon. Another important, really key investment there. We received $9.2 million to develop specialized unit at the Oregon State Hospital to treat patients that are not responding to current treatment and require intensive services. Some of this funding came through an e-board action earlier in the legislative session for complex patient care at the Junction City single unit remodel. And you'll see here as well that we received $6 million to address workforce gaps, especially in behavioral health programs. So that's through our healthcare provider incentive program. $15 million to reduce current gaps in residential treatment beds. And then a very key investment that was also quite high profile is the 988 call line. So the budget includes $32.9 million to support 988 crisis line from the newly passed cell phone tax in House Bill 2757. And then legislature also allocated an additional $13.2 million in general fund to support startup expenses until the tax revenue is collected. And then leveraged with the additional investment of $29.3 million in federal funds. So that's how we get to the 75.6 here. All right, next slide, please. So just moving on with the behavioral health investments, $3.1 million was allocated to OHA to provide incentives to recruit and increase the number of child psychiatrists and developmental pediatricians. $6 million was provided to us to ensure more effective community-based placements that help more Oregon State Hospital patients leave the state hospital sooner after they no longer need hospital level care and help get them into community settings independently and safely. And then $7 million is noted here for community mental health programs to support and expand community-based treatment for people with severe psychiatric illness or those requiring civil commitment services. And then last, there was a $6.5 million investment to ensure more people with mental health disorders receive treatment in the community instead of being held in jail. And then my last investment slide before we get into some of the key bills is related to public health. So the investments here, I think the major investment is $50 million to accelerate the modernization of Oregon's public health system. This was, I would be remiss if I didn't mention the incredible advocacy that came through community-based organizations, local public health, tribal governments as well, who received this funding. Just really recognize the important foundation that was built during the pandemic and the need for additional resources to continue to expand and support the work around highlighting, and addressing gaps that mark our public health system. So it will support state, community, tribal, and local efforts to mitigate health inequities related to communicable disease, chronic disease, emergency preparedness, and reproductive health. The budget also includes $6.1 million to expand Oregon's home visiting program, to scale up the next phase in Oregon, to connect families with newborns to resources. OHA was provided $1.5 million to address a funding gap in the prescription drug monitoring program, $4.4 million from the Juul e-cigarette settlement to be used for vaping cessation, particularly focused on supporting young people to quit or to never start. $3 million to fund public health interventions in the lower Umatilla Basin groundwater management area, including outreach for well screening and testing, water treatment, just really important effort there as we're faced with a crisis around domestic well water and safety. And then last, you'll see that the budget includes $7.3 million in fees and general funds to support OHA to develop and implement the first in the nation psilocybin services regulatory framework. So with that, I'm going to pass to Kaz to talk about key bills related to the opioid crisis.
Thank you, Ashley. I'm going to buzz through these pretty quickly because I'm quite conscious of time, but I'll give as much detail as I can given the constrained time circumstances. So SB 1043, if we can move on to the next slide, please. SB 1043 does exactly what it says there, allows folks who are discharging from treatment in hospitals to receive opioid antagonists. 2395 has a range of different measures. It includes opioid kits or naloxone kits in public buildings. It allows OHA to engage in bulk purchase, which obviously has positive price implications. It allows law enforcement, fire, and EMTs to distribute opioid antagonists. It makes educators civilly immune if they administer an opioid antagonist to a student that is overdosing, decriminalizes testing equipment, and a few other provisions as well. But those are the kind of main headlines. SB 450, a little bit of a technical one, but still important. Basically, it reduces the administrative burden when it comes to administering nasal opioid overdose drugs. So again, just trying to lower the barriers to get these drugs out into the community where they can be used. And 238, SB 238, starts the process of educating people about synthetic opioids like fentanyl. That one will be implemented from the 24-25 school year. So starting in September 24 is the aim, and the curricula are being developed by OHA in collaboration with the State Board for Education and the Alcohol and Drug Policy Commission. Next slide, please. So alongside the opioid crisis, we're aware that we're facing some pretty severe challenges in behavioral health. We did have, as Ashley alluded to at the start, a pretty challenging session. So a lot of what was initially proposed didn't quite end up making it to across the finish line. Nevertheless, there are some pretty big pieces of legislation that came through. HB 2513 is a range of technical fixes for Measure 110. Again, too many to go into, but I think the key thing is that it clarifies the role that OHA plays versus the role that the Oversight and Accountability Council plays. Always struggle with that acronym. It creates a director position within OHA, so one person being responsible for the entire program. Then a few other technical pieces. It reduces the admin cap that existed, so that allows for more administration, requires CMHPs and behavioral health resource networks to coordinate. Before it was possible, now it's a requirement. And a few other bits and pieces, pushes out the Secretary of State audit by a year because the entire program has been delayed by around a year to 18 months. Again, a lot more there, but those are some of the key highlights. HB 2757 and the related bill 3426, again, Ashley alluded to this earlier on, provides funding for the 988 crisis line and mobile crisis centers. The way that the funding situation works there is that any money generated by the tax will go first to 988 crisis centers. And then if there is money left over, which we anticipate there may well be, then that will be spent on part funding the mobile crisis centers. So the actual response, not just the line. 3426 makes it a requirement that people who are responding to those calls, people who are at the call centers, are trained in giving specific advice and help to folks who are first responders. Those folks see some pretty difficult things. There are much higher rates of mental health issues than the general population, and so having training that's specifically tailored to those that experience as part of their jobs some of the most traumatic things a human being could see is one of the things that the legislature prioritized. 2235. Not much to say on this, but it is important in the sense that it creates a behavioral health workforce group. It has 21 members, and it's due to report in January 2025. It has a pretty broad remit to look at the overall pipeline, what kind of barriers there are to folks joining the behavioral health workforce and what can be done to address them. 2767, this one doesn't have a lot for OHA to do. We've included it simply because it's part of that wider behavioral health spectrum. We currently have one recovery high school in Oregon. It's a model that is seeing increasing interest, and as a result, this bill has passed. It establishes the requirements for moving those forward. And so that basically makes it easier for future schools to be brought forward. 968 modifies some statutes relating to the System of Care Advisory Council, which focuses on young people and the entire spectrum of care that they would receive if they're experiencing behavioral health, mental health, and substance abuse issues. It was established, I think, 3 years ago now, and over the course of the last few years, become clear that it needs a bit more capacity. It needs some expansion of its overall statutory authority. So that will hopefully help with coordination between different agencies. Next slide, please. And again, very conscious of time, going to try and get through these as quickly as possible. 2405 is a bill that allows for transportation of patients back to their home jurisdiction. So if there isn't somebody to pick you up when you leave the state hospital, there were in some cases situations where folks were discharged into Marion County when they weren't from Marion County. So this begins to address that issue. 2921 is part of a broader package of workforce legislation. It requires hospitals to file demographic reports with the Department of Labor and Industry to really get a sense of whether the workforce in hospitals in general, and this applies to the state hospital and to other hospitals, acute care hospitals as well, whether those are reflecting the community they serve. And that's particularly important when we're dealing with the state hospital and in areas like peer support, for example. Seeing somebody who has a similar lived experience to you can be a really important part of the recovery pathway for those experiencing mental health and behavioral health challenges. SB 321 creates essentially an appeals process for anybody who is found guilty except for insanity. And so that enables an important judicial safeguard that didn't previously exist. And 629 modifies the membership of the State Hospital Advisory Board. That board has struggled to reach quorum in the past, in part because there were geographical limitations on where they could get members of the public who might be interested in attending from. This expands that, makes a few other tweaks and changes, but the goal here is really to make the board a leading force within the hospital. At the moment, it's probably a bit on the back foot and not as effective as it could be. So that's it from me. And I will hand over to Phil for all of the 4 minutes remaining.
And Phil, maybe if in the interest of time in the next few slides, if you could pick maybe two to do the, yeah, go ahead.
Happy to. So you all, thanks for having us. And you all have heard a lot about studying the CCO Quality Incentive Program. We did get that bill through, and we'll be studying that in a co-creation model with community, working with CCOs and other interested parties to figure out how to eliminate health inequities and center health equity in that program. 972 you heard about earlier, moving to a state-based marketplace, very exciting. It'll take a few years, as Laurel mentioned, but we do have authorization to begin that process, and that's really really a big step forward for Oregon. I'm going to skip over SB 1089 because DCDS is the lead agency, but just wanted to say that OHA will be, is tasked legislatively with consulting on that bill and being a partner about the changes that that governance board might propose and what it would mean. Would we need waivers, et cetera? We can go to the next slide. We did, the legislature did see fit to push back the CCO contract procurement by 2 years, which was due to the amount, the waiver and many of the other programs that you all are tracking that OHA is implementing. The policy board will be very instrumental to that next procurement extension, that procurement, but we will have a little more time to do that with some thoughtfulness and to center the voices of community in that and not rush. I want to skip down to SB 216, which is about making sure that there's confidentiality for REAL-D and SOGI data that OHA collects. That is not protected health information in the past, and so this clarifies that people whose information is collected or who offer that information have that safety that we're going to keep it confidential And the flu vaccine for all allows pharmacists to dispense flu vaccines to people, kids down to 6 months of age, which will remove a barrier for families looking for that. And we can go to the next slide. Oh, you know what? Actually, excuse me. I skipped over a couple of very important ones. You mind going back one slide? HB 2002, which was the, excuse me, sorry, I'm just skipping around, was the subject of a lot of the heat and noise during the legislative session, did eventually pass. Medicaid will be implementing parts of it because it is a mandate to provide care and some protections for folks seeking that care. Really big, important equity issue. As I said, it was very contentious, but OHA will be taking the pieces that are delegated to it and moving them forward, and making sure that we comply with this law. I think the tribal savings is a fabulous codification of an existing program. And so we can now go to the next slide. Thank you. And just briefly, there was a very carefully negotiated package between labor, hospitals, other provider organizations around staffing. There were several pieces to it. There's the first one that you see on your screen, 2697, which sets new actually staffing ratios for a variety of staff at hospitals, and not just nurses, and helps to make sure that hospitals are staffed adequately. 3396 was another piece, which is to sort of really boost that workforce and try to open the pipeline of workforce and training for the staffing that hospitals and other providers really desperately need. And then last, a piece that was of probably interest to the board and to the agency, which was a legislative carve out for the costs associated with frontline worker salaries, carving them out from the cost growth target program, so that they're not considered as part of the trends and the costs that the providers report to us. So I think with that, that is it. And turn it back over to Ashley. Appreciate your time and all your attention during this legislative session. We really appreciate the board's support.
Yeah, thank you all so much. I know we're at time, so I'm happy to come back at another time to dive into any of these bills and implementation.
Yeah, well, thank you so much, Ashley and Philip and Kaz, for your presentation. I apologize that we had to shortchange you a little bit for your presentation today. Maybe if we can get out of the slides and just sort of see if any of the board members have a pressing question for the government relations team. All right. Well, again, thank you for all your excellent work. Congratulations on all the progress that you made this session. I know it was a challenging one, so congratulations. And we look forward to hearing more from you in the future. So with that, I just want to remind folks about the webinar that we're going to have next Tuesday at 8 a.m. about the Basic Health Program. And then also just a reminder that our next Oregon Health Policy Board meeting is on Monday, August 7th, and it's going to be in Hood River. So looking forward to seeing folks in person in August. Have a good rest of your day. And thanks so much for all your time and attention and all the excellent work that you're doing. Bye, everyone.